All right, is everyone ready to begin? We have our last class session before the final. The final is written, it has been reviewed, and it is now set in stone. I've gotten clearance for you all to tell you to make sure you bring a calculator for the test, because there's going to be some math problems in there. They're not too difficult, but you probably do want a calculator for it. Yes, sir.
Is there like a specific kind of calculator that we need?
Non-programmable, just abacus is fine too if you like. I'm kidding, don't bring an abacus, it's going to be silly. No, just any basic calculator is totally fine. If you can do multiplication and division, I think you're probably pretty good from that standpoint, right? So again, it's going to go back to like Pete's dosing stuff, right? So remember like our fluid calculations, remember how we figure out from say an oral suspension, a concentration, and a dose, how do we figure out how much to give that patient? That's the sort of thing we're looking at. And again, those are easy points, right? Because if you can do that math, and it's fairly straightforward once you practice it, that's easy points for you, right? So it shouldn't be too big of a deal. Don't let that stress you out too much there. Also remember our kinetic principles. Really the big one you have to remember is that C0 equals dose over VD. Don't forget that one, right? Because again, you have to know conceptually what those differences mean, but also if I gave you a dose and I gave you a volume distribution, you should be able to tell me what? Yeah, what concentration you expect to see in that patient. And that's really important for what we're talking about today is this therapeutic drug monitoring. Any questions on anything else before I get started here? Yes, ma'am.
How many questions?
It'll be 50 questions, 5 answer choices apiece. I did not specify a time, so whatever I guess the standard is, they will probably set that up. I will not be here. I think it's Wednesday, right? Thursday? Okay, I won't be here for that day, but that should be pretty standard, I think.
Do we get the 2 hours or do we get the 50 minutes?
I don't think it's 50 minutes, but double check with your campus administrators. Double check. I don't want to tell you something that's wrong, right? So I imagine they'll give you enough time to finish the test, right? Yes.
So it's cumulative, so is it gonna be like mostly the last 2 lectures, or will it be even
I didn't do the
across?
percentages necessarily, but it'll be roughly representative of the whole course, I think. So it's not necessarily I'm doing 75% on the new stuff and
Okay.
25. It's because again, a lot of this stuff builds on itself, right? So again, the kinetic principles we learned early on are going to be affecting the Jerrys and the Neos and things like that. So because of that, it's hard to really separate a lot of that stuff out. Okay, so just be aware of that. Yes, sir. Oh, that was a question? Yep. Okay. Anything else? I know the test is what's looming on your mind, but we got lots of content to cover. So, and some people ask that if I need to go over, or is everyone okay with staying and me going over? If you really have somewhere to be, you can always get up and leave. I'd be recording it anyway, so you can just catch up on that if you really need to. Is everyone fine with that? Show of hands. Yes, okay. You can leave if you like. I'm not going to feel too bad about that. So, anywho, getting into it, let's talk about therapeutic drug monitoring, right? So, what is therapeutic drug monitoring? We've mentioned it before. Monitoring drug levels, right? Or we're measuring the drug levels to make sure that we're staying within that therapeutic window. And do we do this for every drug? We do not, right? We actually do this for a very select number of drugs, but which ones do you think we do this for? Yes, the ones with a narrow therapeutic index, for that walking that line between toxicity and therapeutic effects is going to be fairly narrow. And so some of the things we might be measuring here, just in terms of definitions, when I say a peak level, anyone know what that means? At the highest level you achieve, when do you get that peak? Generally soon after that dose is given. It depends on the route of administration, right? So which route do you think would have the fastest peaks? IV probably, right? Because again, I put it right into the bloodstream. Within 30 minutes or so, it should be equilibrated, should be able to get that peak level pretty easily. Something like an oral dose would take a little bit longer, maybe a couple of hours before you'd see it really hit its peak level there. So you have your peak levels. What's a trough? It's the lowest dose, the lowest concentration you achieve before you give the next dose, right? So again, if you're looking at this graph here, you can see after giving a dose, you'd see that you'd hit a peak level. You'd then be dropping down, and then before, now again, if I only give the one-time dose, you'd see that the levels would then eventually drop down to 0. But remember, we don't do that. We dose to get things to a steady state level, and so then at that trough level is when I'm going to give another dose here, right? And that way I'm going to get that nice sine wave when I'm at steady state between peaks and troughs. Now remember, I could give a continuous infusion of a drug and achieve that same steady state concentration, But this achieves the same average level, right? So again, between that peak and trough, you should be getting an average level. That's the steady state level, essentially, okay? So remember, we could dose things very differently. So we could do, say, for instance, a very big dose less frequently, or I could do a smaller dose more frequently, right? So what is the benefits of maybe doing a bigger dose less frequently? Better compliance, right? If I'm giving something 1 time a day versus 3 times a day, that's easier for patients to keep up with, right? Easier for nurses to schedule in terms of administration. They have a lot of other things they're doing with the patient. That can be an important consideration. What's the drawback based off this graph? Higher peaks, right? So which you can see what? Toxicities, and then how about a low trough? Won't be as effective, right? So for instance, if I need to keep my level, say, around 5 in order to kill off a bacteria, but my levels keep dropping below 5 towards the end of that dosing interval, it may not retain that efficacy, right? You may find that the drug is not being that effective. So what can I do to get around that? Well, I can give it a smaller dose less frequently. What happens to the average steady state concentration? It's identical, right? It doesn't really matter. So in some cases, it's okay to give bigger doses less frequently. It just depends on the drug, and we'll see those examples as we get to them next semester. Remember, how long does it take to get to steady state? 4 to 5 half-lives, right? So for instance, some drugs may only take about 24 hours to get to that steady state. Some drugs may take much longer than that. Is there any way to circumvent that 4 to 5 half-lives? Yeah, our loading doses help us to get to that concentration immediately, and then we use what to keep us there? Maintenance dose. Good. So again, the terminology is important to remember that. So and again, anytime you're giving a drug intermittently, meaning via schedule but not continuously, you're going to find that you're going to have those fluctuations. There's just inherently going to be peaks and troughs you're going to be dealing with. So looking at the clinical pharmacokinetics, basically is how we're applying these terms, we're applying these principles to try to prospectively determine how do we dose a patient, right? If I have a patient comes in and they're morbidly obese, I may change my dosing strategy versus they came in and they were cachectic, right? Doing that sort of thing helps me to prevent from getting to toxic levels and helps me to make sure I'm getting to efficacious levels right off the bat, right? It's a prospective sort of thing I do. The therapeutic drug monitoring, though, is after I've been dosing them, I get that level back, and then I'm now reactively changing my dose based on those levels, right? So again, you can look at a patient and say, okay, you're 100 kilograms, you're an adult female, I can know these things about your kinetics with this drug, but those are averages, right? And do people fall outside of the average? Absolutely they do. There are outliers all the time. And so once I get those levels back, now I know how that drug is working in that particular person, I can then customize it. I can make it much more patient specific and dose it to where it's going to be the right dose, the right timing just for that particular person. Okay, that's part of that therapeutic drug monitoring. And we're using, because again, what are we actually measuring? Like what samples are we using? Like CSF samples or urine samples? Serum samples, right? We're taking blood and then measuring that. So again, we're using this as a surrogate. Even if I'm using a drug to say, for instance, treat seizures, which is working presumably in the brain, I'm not measuring brain levels of the drug. I'm measuring a serum level, and I'm using that as a surrogate because we've correlated that to say, okay, well, if I have this blood level, this should equate to a good level in the brain to treat that seizure, right? So again, these are all just surrogates for what's happening at the real site of action. So as I mentioned, we're using these serum concentrations to see are we actually getting to where we need to be in terms of hitting that Goldilocks window, right, of making sure we're efficacious without getting into that toxic period there. And so by understanding what are the potential benefits and the limitations thereof and how to actually apply it, you're going to make much more judicious use of it and to make sure that you're saving money and you're also doing it appropriately by your patient, right, to make sure you're kind of maximizing their therapy. So, and again, early when we were doing this, we were trying to establish what we call a therapeutic range, right? So that's that range we're looking at between what's the lowest level to achieve efficacy and what's the highest level before we start to achieve toxicity. And so we established that window so that way we have something to shoot for in terms of where the patient can be at to make sure they're appropriate. Now, when I say a therapeutic range and I say, for a drug, it's 10 to 20 micrograms per ml, does that mean that everyone has to be within that range? Otherwise, it won't be efficacious? No, there are some people that do just fine falling outside of that level. That's going to be one of the principles we're looking at here is that you have to correlate these numbers that you receive back from the lab to the patient. If you don't do that, you just look at a number and react off of that, you can potentially make some errors, right? And again, it goes back to the mantra of you treat the patient, not the number, right? That's a really big thing to consider there. Always correlate these lab results that you get back to your patient to say, okay, does this make sense? What other considerations do I have to make before I react to this number? Because a lot of times you get a lab back and it says it's off, right? The lab calls up, hey, potassium's high. They go, gosh, I got a patient with hyperkalemia. Could just be that the sample hemolyzed, right? There's a lot of reasons why things can come back incorrect that may not be really that clinically relevant. And a lot of times, the best thing to do for your patients is to do nothing at all, as we'll see. So there's a lot of cases like that. Anywho, so as I mentioned, that therapeutic range is shooting for that window between where she should be achieving efficacy before we get to that toxicity. And if you remember looking at our therapeutic indices, remember that we're looking at that ratio between the toxic dose 50 generally and the effective dose 50, right? It's that ratio there. And generally, what do we like with that ratio in terms of numbers? Like bigger numbers, smaller numbers? Yeah, the range. We want to have a big range there, right? We'd like to have zero overlap if possible. So that means a bigger ratio between that TD50 to that ED50, right? So bigger numbers are better there. However, a lot of these drugs are going to have that overlap there. So even if you're at an effective dose for a patient, you're still going to be very likely to see toxicity, okay? And again, depending on the drug, you may find that the slopes of the curves can actually change pretty dramatically. Right? Remember, if we have a very steep sort of slope here, that means that very small changes in dose can lead to big changes in terms of who's going to be developing toxicity. If it has a more shallow sort of slope there, it means you can have kind of wider changes in dose with relatively small changes, right? Again, look at this narrow therapeutic index, so look how much overlap there is between the therapeutic dose and the toxic dose there. A lot of people who are going to be therapeutic technically are going to be at risk for that toxicity there. Just like when you're looking at something like warfarin, right? We mentioned warfarin is what kind of drug? It's an anticoagulant, right? We know we use it to thin the blood to prevent clots, but on the flip side of that, what's the big toxicity you worry about? You thin it too much, and thus you have bleeding, right? So again, you have to ride that line pretty narrowly to make sure you're getting the clinical effects you want without causing them to bleed out. And again, we're looking at the dose that we're giving the patient. We're going to see that every patient has some degree of pharmacokinetic variability. Everyone's a little bit different in some of these cases here. When you look up things in lexicon, right, when you looked up for your homework assignments, things like the volume of distribution and the metabolism and the half-life, those are averages, right? Those are averages based off of some sample they did, and they looked at those patients, usually from those phase 2 and 3 trials, and they said, okay, well, what do we think are the averages here? And just note, how many patients were they using for those clinical trials? At a maximum, are they using like millions of people? Maybe thousands, right? So again, people are going to fall outside of that just because of the patient population they were using, right? So anyway, so they should get some concentration at that site there. And of course, everyone has some degree of pharmacodynamic variability here, and we can't really account for that so much. But we can look at the patient to see, okay, well, they're still having seizures. Well, maybe they're not getting enough drug, right? Or they still, we're giving them an antibiotic and their white count's still high and their fever's still up, right? Obviously, that's not working. So some of that we can try to account for. But the main thing we're going to be focusing on is the pharmacokinetic variability, because I can't change how the patient clears the dose, but what can I change as a clinician? The dose I give and how often I give it, right? Those are the two big things we're going to be looking at. And again, there's a lot of reasons why patients may have variations in response here, right? A pregnant patient is very different pharmacokinetically than a non-pregnant patient, right? They have a lot more volume they have to deal with. Their blood pressure is going to be different. Their proteins are different. Everything can be very different there. Genetic differences, right? What's the term for genetic differences influencing drugs? Pharmacogenomics, right? You got to know your definitions for the test, right? And again, it's going to provide variability for all of these. And so what you're going to see here is by using therapeutic drug monitoring, we can try to individualize that dose to make it much more personal for that particular patient, and thus you're going to achieve better results with those patients there. As I mentioned, this is applied to a relatively small number of drugs, but they can sometimes be drugs that you use very frequently. So if you work in the hospital and you're working in the ICU or on the floor, you're probably going to be using a lot of vancomycin. It's an antibiotic you use pretty frequently. You're probably going to see a lot of aminoglycosides like gentamicin and tobramycin. So even though it's a small number of drugs, these may be workhorse drugs for you that you use very frequently. You at least want to be aware of. Now, for certain drugs, we don't need to necessarily measure a blood level to determine if it's being effective or not. If I'm giving you an antihypertensive, what can I measure to see if it's working? Just a blood pressure, right? It's much less invasive. I don't really care what the drug level is. I can just look at your blood pressure to see how you're doing, right? Serum cholesterol, right, is another thing. I don't have to measure my anti-hyperlipidemia drugs. I can just go ahead and look at your cholesterol and see if it's working or not. Other things as well, so for instance, like drugs with other measures. So warfarin, I don't measure warfarin levels, but what I can do is measure that PT-INR, right? That tells me how thin the blood is in terms of how long it takes to clot, and tells me how effective the drug's going to be, okay? So again, if they have these other measures, then I'm not necessarily measuring the serum level of the drug, but I have another good measure there. So for instance, PT-INR monitoring for warfarin is still considered therapeutic drug monitoring, even though I'm not looking at the warfarin level specifically. Okay, so the assumptions you're making when you do TDM or doing therapeutic drug monitoring is that, one, you should have the ability to adjust the dose to make it more individualized for your patient. If it comes only as one type of dose and there's no real ability to change how often you're giving it or the dose itself, then you can't really do a lot of changes with this. So that's rare that you would run into that, but that's one thing to note. Another assumption here is that drug concentration is a better predictor of response than just the dose that you're giving them, right? So that way we've correlated that dose that you're giving and that concentration to actual clinical effects. That's another assumption we're making there. And there should be a good relationship between drug concentration and pharmacologic response. So assuming that as I increase the dose, I should see a bigger response, right? Vice versa. If I lower that dose, I should see less of a response. Now again, looking at this, as I mentioned before, there are certain things that clinician does not control. So for instance, the bioavailability, right? I can't change how well the patient absorbs the drug. Although I could change a few things, right? Which route I give the drug by, if there's any drug interactions or food interactions, I can try to educate on that. But I certainly can't change the clearance, not unless I institute some kind of drastic measures like putting the patient on dialysis or something. So this is rare that we'd ever change these specifically. However, the dose and the interval are the big things that we have control over. In general, you're going to find that you typically want to change one or the other, either change the dose for the patient or change the interval. What happens if you think if you would change both at the same time? Yeah, you might see too big of a change, right? You might end up over or undershooting your levels there, and then at that point you're kind of like, well, okay, what do I do now? Do I change them both again? It becomes a little bit more difficult. So in general, and guys, a good rule of thumb, just change one or the other. Now, the therapeutic ranges, as I mentioned, are not absolute, so you can have patients that do very well and have good therapeutic effect when they're below the level that is considered to be therapeutic. And you may have patients that manifest toxicity even at a normal therapeutic level, right? So you're going to have patients that are going to fall on either side of that. And so this is just based on the averages. It's based on the probabilities. And so, for instance, if I have a patient who I suspect is having toxicity from a drug, but their level comes back and it's normal, what do I do with that? What would you think? Does that just say, well, I'm sorry you're having toxicity, but the drug level is fine. We can't do anything for you. Well, no, you'd say like, well, obviously we need to do something about this dose. Like maybe you need to change the drug. Maybe you need to change the dose or give it less frequently because that's obviously too much drug for you, right? On the flip side, if I have a patient with a low level and they come in, they're saying, hey, the drug's working great for me. I'm having no problems. What do you do then? You may not want to do anything, right? Okay, well, the level's a little bit low, but okay, you're not having any issues there. What if it was something that you're treating that's relatively infrequent? So this is always a troubling one where you have patients with seizures, right? And sometimes it can be very variable in how often a patient will have a seizure. It could be weeks or months between episodes, right? So you're giving them a drug and you're like, okay, well, they haven't had any seizures for a while. Is it the drug that's working or is it because they wouldn't have had one anyway? You tell the difference? Not really, right? So that's why it's really tough. That's why you use the therapeutic concentrations to try to at least say, well, I know they're in range and they haven't been having any seizures, so you have to make that reasonable assumption. Okay, the drug must be working, right? Just like I have this can of elephant repellent up here. It works great, right? Have you seen any elephants around here? Exactly, it's working. Well, no, there's no elephants around here to be had anyway, right? So that's kind of the analogy I'm going for there. So it depends on the situation. Anywho, obviously not a very good analogy, but anyway. So looking at this, you're going to see, again, that range should be predicting when you're going to achieve toxicity versus when you're going to achieve the efficacious ranges there. But always remember, treat the patient, not the number. Sometimes the best thing is to do nothing at all. Sometimes you just need to repeat the level. Sometimes you don't need to necessarily go and just change a patient's dose altogether. Okay, other things you're going to see here is that, again, the range was generally characterized in a small population. So considering where these levels were done at, it may affect, the kind of patients you're dealing with now. So for instance, if a therapeutic range for a drug was established back in the 50s, do you think our population is the same today in 2019 as it was in the 50s? Well, generally no, right? We've changed as a nation in a lot of different ways, and so because of that, you may find that it may not be directly applicable. So always have to consider that maybe this is not the same population I'm used to dealing with. Again, a lot of times we use this old data as a good rule of thumb, but again, we have to make sure that we keep that in mind that, okay, this may not be the absolute range we're shooting for there, okay? All right, so again, when you're shooting for a target concentration, typically you don't want to just say, hey, I'm going to shoot for 10 to 20. Try to shoot for a specific number when you're trying to decide a dose for a patient. Say, I'm going to go for 15, right? That way you always shoot for the middle of the road there. And in general, you're going to assume your patients are acting like a average member of the population, okay? So coming in, if I was just looking at a relatively otherwise healthy patient, I have to assume, okay, well, they're fitting within within those average pharmacokinetics. And that's going to help me to establish what my initial dose and dosing strategy is going to be for those patients. Based off of that, then we can actually figure out their kinetics and go ahead and calculate a dosage regimen. So when you have a patient who's coming in, for instance, and they need to have, say for instance, vancomycin given for them, right? Vancomycin, I mentioned, is an anti-infective. Anyone know what we use it for? Ever heard of MRSA? It's a big one we use it to treat there. So we give it for MRSA and other gram-positive bugs, and we'll learn a lot about that next semester. But based off your patient, a lot of them, we give it to them empirically until we can rule out they have infection. And so when you look at a patient like that, you can say, okay, well, I know the weight of the patient and I know their renal function. Based off of that, I will come up with a generalized standard dose. I say, okay, for this patient, they're going to get 1 gram of the drug every 12 hours. For this patient, because their renal function is a little bit worse, I'm going to give maybe 750 every 24 hours, right? You don't have to memorize those numbers, but just for an example there. That's assuming they have those same average kinetics there. Doesn't mean that when I get those levels back, once that patient's at steady state, that they will be in the therapeutic range. There's a good probability they will be. But once I do that and I standardize that dose for them initially, then I get the levels back, and then I can try to personalize it even further. Okay, so those are some of the kind of the general kind of flow of things when we do this. Now, again, we said that it's going to be 4 to 5 half-lives until the drug is at steady state. What happens if, say, for instance, the nurse draws a level too soon? Is it going to look falsely high or low, do you think? Falsely low, right? And so because of that, what's your instinct to do? To increase the dose, right, or shorten the interval, right? So in those cases there, you have to be careful and really look at the documentation. Documentation is super key for this stuff, and I'll give you some other examples of that in a minute. But typically, you assume that you're at steady state, you get the level back, and you kind of have two scenarios, right? So scenario A is that you have an adequate response, patient looks like they're doing well, white count's coming down, fever's coming down, they're clearing that infection, you just continue treatment as is, right? Or, in a lot of cases, you may find that the level comes back and it's either subtherapeutic, or it's supratherapeutic, or potentially in the toxic range, and then at that point, you can try to make your determinations on if I want to change the dose or the interval, right? Now, if my level is low, what could I do to the dose to get it up? Yeah, it makes sense, right? You would increase the dose there. If my level is low and I wanted to change the interval to get it into the range, what would I do? I would shorten the interval, right? I would decrease that interval. Maybe go from every, say, 12 hours to every 8 hours, right? So again, think about that, because that one's a little bit counterintuitive in terms of the interval there. Obviously, if the dose is too high, you drop the dose. If the level is too high, what do I do to the interval? You extend it out, right? So at that point, you say give from every 12 to every 24 hours, right? So again, what are some reasons why we might actually want to? Oh yes, ma'am.
So how do you know if you want to change the dose or the interval? Is that just something you just kind of like, I'm going to try this one that time?
You don't necessarily go quite that like I'm just going to try it, right? You don't necessarily do that necessarily, but what you can do, though, is you have to consider several factors, right? So oftentimes it's easier just to change the dose. When you change the interval, you have to think about what the implications are for administration, right? So I like to think a lot about the inpatient side of things just because that's my realm. If you try to tell a nurse, say, on a busy med-surg floor where they have, say, 20, 30 patients that they're responsible for, I want you to give this drug every 6 hours, they're going to yell at you. And they're not going to do it, right? Because it's just physically impossible for them to manage that on top of everything else they have to do. And so sometimes it's a consideration there in terms of feasibility of administration. Sometimes there are other issues at play. And we can talk more about that as we get to specific details here. But in general, you'll have a feel for if I want to change the interval or if I want to change the dose and kind of where you're at from that standpoint. It's a little bit easier, but it may not. It depends also, are you trying to achieve a certain peak or is it the trough you're dealing with, right? And so we'll mention that as well. So it depends on the drug, depends on a lot of different features. Yep. Of course, most answers to your questions are always, it depends, right? There's always a million different reasons why it depends. But so anyway, what are some reasons why we're going to use our drug concentrations? Again, this gives us additional information to correlate with the clinical picture, right, to determine, okay, how well is this drug working for these patients here, and helps to determine that status. And again, this is going to help us to individualize that dosage regimen for them. Now, other things we can do is we can try to check to see if the pharmacokinetics have changed at all for this patient. So for instance, if I have a patient going to the ICU for sepsis, and I'm worried about the renal function changing, causing the drug to be cleared less effectively, then I may want to check a level just to see if the patient's getting too high. Maybe the first dose I started them on was great and I got appropriate levels, but now the renal function is tanked. it's a good reason to check another level to see, okay, well, is my level too high now? Because they're not able to eliminate the drug as well. Or if I'm introducing something like a drug or food or herbal interaction, right? If I introduce, say, a CYP inhibitor that affects that drug, then maybe my levels are too high now. I need to check that out and then look at a level to see if that is too high. And other things you could do, adherence, right? Why would I check a level to check for adherence? Because if it's negative, then obviously not taking the drug, right? So again, that can be another reason why you might want to check that. I remember when I was in on rotations, when I was in school, I was rotating around this pain management pharmacist at an ambulatory clinic, and they were testing levels. They had a patient who was on hydrocodone for chronic pain, and they're doing, they did a random urine drug screen, and the guy was negative for it. So they ended up kicking him out of the practice. And I said, well, why would you even test for that? Like, why would you need to test to see if the patient's taking hydrocodone? They're like, well, he came back negative, so what does that tell you? He wasn't taking it. Presumably, he was doing what? Selling it, giving it to someone else, right? Maybe he preferred crack cocaine to hydrocodone, right? And so maybe he sold that in order to get money for that, or maybe who knows what, right? We don't know what our patients are doing outside of the clinic. But point is, you can check for adherence in those cases. There, it can be very useful, right? Anyway, other reasons why we might check a concentration is toxicity suspected. Are we getting a lack of therapeutic response? Again, the adherence thing comes up quite frequently as well. And then oftentimes once we make a change in therapy, we change the dose of the interval, you can go back and check the level again to see once they achieve that new steady state, are they now in range, right? You want to check your work to make sure what you did was appropriate there. Changes in clinical status of the patient, and then also his interactions. These are the most common reasons why you'll generally check a level for a drug. Now, information you need in order to make a determination on a level, right? So you get the level back from the lab, but you need to know the context for that level. So for instance, what are some things you want to know? The time it was taken, right? So you want to know the time the drug was actually taken by the nurse, right? Is that always accurate? Why not? Right, so what did they forget when they took the level? And they're going back in 2 hours later, and they're typing it in to chart it. You may not know, right? You may get poor documentation there. And again, because humans are all error prone, it's not to say that nurses in particular are error prone, but they are some of the busiest people in the hospital, right? They have a lot of work to do. And so things like documentation of when a lab was drawn may not be on the forefront of their mind if they have something more critical going on, right? So again, always consider, is the documentation done appropriately, right? You also want to know, certainly you want to know the sample was taken. What else do you want to know? When the drug was given, right? Because you need to correlate, okay, the drug was given at 8 o'clock, and now this level was done at, say, at 6 hours later. Then I can now make a correlation in terms of like, where was this at along the spectrum, right? Was this a trough level? Was it a peak level? Was it somewhere in between, a random level? Who can say? But that's why we need that documentation at that time. You also want to know the dosage regimen, right? So if I know I'm giving it every 8 hours, and I get a 7.5 hour level after the last dose, I know that's a trough level, right? Or if I know if it was every 24 hours, it's gotten 30 minutes after the drug was given, then it's a peak level, right? These are things you can interpret there. You want to know your patient demographics. You want to know concurrent medications that they're on that may be affecting this. And then also, what's your reason for monitoring? Now, one thing you may consider is if you order a level for a patient, say you're in the hospital, are you always the person who's going to be responding to that level? No, right? You may have someone, you may go off shift, right? You may go home and someone else is coming on, and your colleague needs to know why you got that level in the first place. Otherwise, they may not know what to do with it, right? That's why a good sign out is super important, right? Being able to sign out things like, hey, I got a level coming back at 12 o'clock for this patient. Can you please make sure you address this? If it's this, don't do anything. If it comes back high, then do this, right? That's an appropriate sign out. You need to really make sure you do that to make sure continuity of care is maintained there, right? And then also, what is your desired range, right? So sometimes drugs may have multiple ranges depending on what the indication is. As an example, if I have, say, for instance, someone getting vancomycin for a gram-positive infection, and I'm treating a cellulitis, that's a relatively easy spot to get to for the drug. I can dose it, say, at a level of, say, 10 to 15 micrograms per ml. Versus if it's meningitis, that's a lot harder to get to, because again, it's in the brain. In the CNS, I need to give a higher level. I may be shooting for a level, say, 15 to 20. So the range can change depending on what the indication is, and it's important to know what that indication is. Yes, ma'am.
What is route also important? So you know how long it takes to reach the target cell?
Yeah, you definitely would want to know the route as well. It would be good information. Because again, if it's oral, it'll have a slower time to peak level. So yeah, it's good information to have as well. Mm-hmm. Now, looking at this, you're going to find for these characteristics for these drugs, there's really no good, clearly observable endpoint, right? We give you a therapeutic range, but that's really just trying to set the average limits there. It doesn't mean people are going to fall outside of that, and they do on a frequent basis. So you have to keep that in mind. Generally, if they're within 10% of a level, we don't really do much with it, right? So again, if I was shooting for a level of 15 to 20 and they came back at 14.5, I'm probably not going to chase that down, right? Because again, making too many changes is probably going to do what? You're probably going to overdo it, right? You probably end up overshooting it or undershoot it depending on the case there. So again, it's one of those cases where don't necessarily do anything if you don't need to. Remember, the concentration is a surrogate, so it's not going to give you an exact concentration of where that drug's working at that site. But again, it's a good idea of kind of what correlation we've correlated that, and that's what we think is going on there. And remember, with narrow therapeutic drugs, typically they have variable pharmacokinetics. So for instance, with vancomycin, it is very much at the whim of the kidneys in terms of how well that patient is clearing it. If the kidneys start to decrease in function, guess what? Vancomycin levels do what? They're going to go up, right? Because the kidneys are not clearing as well. If the renal function starts to improve, vancomycin levels will go down, right? Because again, it's going to be inversely proportional to that renal function in terms of how well we can clear the drug. So again, usually we are concerned with the risk for toxicity if the levels are too high, right? Because again, if a drug was relatively safe, and who cares if I get the level too high, because it's not going to lead to any kind of a demonstrable toxicity, I don't really need to monitor that level, right? It has a very wide therapeutic index. However, for something like vancomycin, if the levels are too high, it can lead to ototoxicity, have hearing loss associated with that, right? You can have nephrotoxicity associated with that. You can actually hurt the kidneys with too high of vancomycin levels, right? So again, these are things you have to consider there. And then also the lack of a response. So if the levels are too low for vanco, perhaps I'm not going to be actually treating the actual infection, and that never gets cleared, okay? And again, we are assuming a stable pharmacologic effect, where if I'm increasing the level, I should see an increase in effect from that drug. Okay, now when we're doing these assays, it's really important to make sure that they're accurate, they're precise and specific, and you have a reasonable turnaround time. When I say that, what does that mean for turnaround time? How long it takes for the labs to come back, right? If it takes 2 weeks, is that super useful? No, because my patient's probably already been discharged by then, right? I'll have patients, I'll give you a good example of this from a toxicology standpoint. If I have a patient who comes in who I suspect has drank radiator fluid, right? It's ethylene glycol. It's a very toxic alcohol substance, and occasionally have people who are either trying to harm themselves or they're alcoholics, and they've run out of alcohol, and this is the first thing they found, try to get their fix. They'll drink that stuff. Now, we don't have a ton of radiator fluid ingestions here in Florida, or windshield washer fluids for that matter, mainly because this is a pretty hot state, right? We don't have a lot of stockpile of that stuff in most people's homes. However, where do you run into it more frequently? Up north, yeah, so exactly. So for instance, I rotated a poison center for a month up in Syracuse, New York, and it was the dead of winter over there. You need windshield washer fluid, you need radiator fluid to make sure that you keep your cars from freezing over. So the interesting thing there is if I have a patient down here in Florida who I suspect has one of these alcoholic ingestions, to get a level done, it takes about a week turnaround time. I have to get that sample, send it off somewhere, then they can report it back. By the time that week is over, my patient has either recovered or they're dead, right? Or they're on dialysis or something, right? So I don't have the leisure to sit there and wait for a level to come back to make a decision on how to treat that patient. If you're up in Syracuse, New York, guess what? You can send off that level and it's back within an hour or two, and I can make that decision. Okay, does this patient actually have this ingestion or not? And then you can treat appropriately. So it depends, right? I'll have physicians who are calling them and say, hey, I want to get a level on this drug. And I'll say, all right, we got to send off the Mayo. It's going to take like 2 weeks to come back. I'm like, okay. And again, it depends on the time course. If you have weeks to work with, then that's okay. If not, then sometimes you need to forego that level to make a decision. And then obviously you'd like it to be relatively inexpensive. If you have to send it off to somewhere specialty, that's obviously going to be a lot more expensive than if you could do it in-house, but that's something you want to consider there, right? So you don't want to be ordering a bunch of random drug levels for things that don't really have any kind of good correlation, because then you're probably going to get a reprimand for, like, why are you costing the hospital so much money? Quit sending off of these levels. It doesn't make sense, right? Anyway, so common drugs that we would do this with include like a lot of anti-infectives. So as I mentioned, these are workhorse antibiotics in the hospital, things like vancomycin and the aminoglycosides. We'll also do it for things like cardiac drugs like digoxin, which we've mentioned previously, and then we'll do it for a lot of our anti-epileptic drugs. Again, because it's hard to tell, is the patient just not having seizures, or is it because the drug is really being that effective? And so we have to make sure they're in that therapeutic range to at least assume that, well, hopefully the drug is doing its thing. And then even some immunosuppressives. Why do we give people immunosuppressives, you think? Suppress the immune system. Yeah, we do a lot for transplant, right? Other reasons as well, potentially for things like certain cancers and whatnot. But yeah, usually it's going to be for things like a transplant or autoimmune diseases. Anyway, so what are some limitations to doing TDM? Usually cost is going to be a big thing, but in the long run, if you're doing it appropriately, you can actually find this to be a cost savings, because hopefully if you can get patients therapeutic, you can get them treated faster, get them discharged faster, without causing a lot of toxicities, right? If I cause someone to have renal failure, because I'm dosing my drug too aggressively and I wasn't checking levels, that can extend their stay, right? That's going to be another complication. And if you, as a clinician, give the patient renal failure, you think the insurance companies want to pay for that? Nope, that's called iatrogenic disease you're causing for your patient. They don't want to pay for that sort of stuff, right? Other things, if there's not a good concentration with the response correlations, you can get a level back, but if you don't know what's therapeutic, then it doesn't really help you out at all, right? Sometimes you can check a level just to see if they're adherent or not, but unless there's that relationship established, it doesn't do you any good for the most part. And then obviously if there are direct response measures, then I don't need to check a level usually. You know, if I'm giving an antihypertensive and the blood pressure is in range, I don't need to worry about checking a level for that drug, right? So inappropriate uses, oftentimes I'll find people that just want to get a level just because. Is that ever a good reason to do something just because? No, generally not, right? So that usually leads to over utilization of resources. You don't necessarily want to do that. You know, is the patient responding appropriately, even though the concentration is a little bit outside the window? You don't necessarily need to keep following up those levels necessarily, as long as the drug is working, okay? If there's been no changes in the patient, you know, if the renal function stayed relatively stable, hepatic function's good, why check a level if you don't need to, right? And then the sample's taken at incorrect times. Why do you think this would happen? Miscommunication is a big one, right? Maybe they missed a dose. Yeah, what else? But the nurse gets really busy if they go ahead and they give that next dose of the drug, and then they, oh shoot, I'm supposed to get a trough level, and they get the level right after the dose is given. It comes back very high. You're like, oh no, this patient's not cleaning the drug at all. But by looking at the times, you can see, oh, actually it was a peak level measuring, not actually a trough level, right? So things like that you have to be keeping in mind. So the benefits, though, what we see here is that, one, we can reduce the number of patients who experience some of these side effects associated with these drugs, and also we keep them in range longer. And it's been shown, as compared to drugs that don't use therapeutic drug monitoring, that we can have some cost benefits, mortality benefits, etc. Right? Decreasing length of stay, very cost effective for the most part, and again, hopefully you're going to have improved efficacy of these drugs here. Okay, so getting into the nitty-gritty of it, how do we actually do therapeutic drug monitoring? So one, you want to make sure you have an idea of why you want to measure that level in the first place, right? So maybe it's been a week or 2 weeks since the last level, and you want to make sure that everything's remaining stable. Okay, that's a good reason. If they're having a lack of response or maybe side effects, you can check a level, okay? Next, you want to make sure the blood sample gets collected. Make sure it's at the right time. Appropriate. If you're measuring a trough level, you want to make sure it's right before the next dose. If it's a peak level, you want to make sure it's right after the dose that was given. If it's a random level, then it can be random. It can be at any point. Make sure it's the right collection tube. Have you had any talks about different tube types in terms of sample collection? You're going to find there's a lot of different ones, and I know relatively a small amount about it, but there's like lavender tops and tiger tops and green tops and red tops and all kinds of different tops. They're designed for different samples to be taken in them, and if someone puts it into the wrong one, you can see issues with it, right? For instance, there's some that are lithiated tubes. I mean, they have lithium in them in order to keep something stable for a particular lab, right? Well, what type of lab do you think that would influence? A lithium level. If I had someone with bipolar disorder and I check it and the nurse puts it into a lithiated tube on accident, guess what? Level looks super high all of a sudden. The patient may look good, may not have any issues, but all of a sudden their level comes back 2 or 3 times the normal range. I'm going to get pretty concerned, and that may be inappropriate, right? Some of the tubes are heparinized. Heparin, anyone know what that does? It's an anticoagulant, right? Similar, different actions, but similar in effect to warfarin, right? It's an anticoagulant, so it's useful for certain blood tests. If I put a sample that I'm checking to see how well it clots into that tube, guess what? It's going to look like it's too thin, potentially. So again, there's different things you have to consider. Make sure the right collection tube was being used in those cases there. Now again, laboratory measurements. You assume everything that comes back from the lab is totally accurate, right? Of course, right? They're the lab. They have to be right, just like the pharmacy. Everything that comes from the pharmacy must be right, right? No, everything is prone to error, right? The machines may not be working appropriately. The lab technicians may have done it inappropriately. We hope they did it correctly, but just be aware that human error does happen there. And then finally, what's the communication of the results, right? And this is why I always harp on units. Always make sure you keep your units straight. I'll give you an example. I talked about the aspirin example where the levels were reported incorrectly. So I was on call. Some of you probably already repressed some memories, but I was on call for the poison center, right? And I get a call for an aspirin overdose, and the nurse calls up and says, "Oh, you know, this patient is overdosed on aspirin." And I say, "Okay, what was the level?" And again, a therapeutic level of aspirin, say 15 to 30, 100 is potentially fatal. So I'm dialyzing patients to get rid of that aspirin, and they say, "Oh, the level's 400." I said, "Oh gosh." I was like, "How's the patient doing? Are they dead?" They said, "No, they're doing just fine. Breathing a little fast, but that's it." I said, "Okay, well, what units were those levels done in?" They said, "Oh, it's micrograms per ml." I said, "Aha." Normally, our aspirin units are reported out in milligrams per deciliter. So that 400, when you convert it over to milligrams per deciliter, was just 40. It's a high level, but not something too terribly concerning compared to a level of 400, right? So again, keeping your unit straight is super important, and that's going to be something I'll harp on probably till the end of our class sessions together, right? Anyway, next you want to take the clinical picture into account. Again, if the level's a little low for an antibiotic, but the patient clinically appears to be improving, their temperature's coming down, the white count's coming down, they look better, you may not necessarily need to chase that level. You may not need to do anything about that, right? And then again, once you decide how you're going to do it, you can either modify the dose or the interval. And again, generally you'll do one or the other. Some cases you may do both, as it turns out. And then once you get that drug, that new regimen to steady state, then you can check another level to see, check your work and see where they're at. If they're too low, maybe they'll be in the right range now, or maybe you overshot it and now they're too high, as the case may be. And again, how do you think pharmacokinetics influences this? It could be so there may be pharmacodynamic variability due to their genetics that influences how well they respond. Maybe a therapeutic level for them is way too much, right? Or vice versa. More often than not, though, you're going to find there's kinetic changes that occur here, right? So remember, those levels are based off of population averages. Those dosages that you see in the books are based off of averages. If someone has, for instance, a slow metabolizing set of enzymes for that drug, guess what? The levels are going to be too high, right? And so again, you're looking at a patient, it's hard to tell what kind of pharmacogenetic differences they have unless you test for it specifically, which we don't have a lot of those. And so again, that's why patients may be outside of that range and why you need to consider those sorts of things there, right? Anyway, so again, the point here is that we can try to find patients, hopefully prospectively, especially if we know their pharmacogenetic traits. So for instance, if they know they are, say, a slow metabolizer of certain enzymes or a fast metabolizer, we can try to select out beforehand to determine if someone is going to have a good response to the drug, or maybe a overactive response, or maybe a poor response overall. You guys ever heard of like 23andMe? What do they do? Yeah, they're genetic testing, right? So again, you spit in a tube or something, and they'll go ahead and run it, and they come back, and it actually tells you certain things in terms of drug metabolism, right? They actually tell you if you're a slow or a fast metabolizer of caffeine, right? So it tells you maybe why you have a good response or poor response to caffeine. If you're metabolizing all of it super quickly, then maybe you need a lot of extra caffeine to get that same kind of kick, right? Versus if you're a slow metabolizer. It's kind of the same thing, right? By knowing beforehand how they may metabolize certain drugs or what kind of differences they have in their kinetics, you may find that you can predict who's going to be a poor responder. Maybe I need to give them a bigger dose off the bat versus if they're going to be a hyperactive responder, maybe I need to give a lower dose. Okay, so little things you might see in the future. And again, by using some of these pharmacogenetic differences in the future, instead of trying to say, well, let's try drug A, and that didn't really work, so let's try drug B instead. And then how about drug D? No, that didn't work. Let's try drug C. Well, maybe D will work this time. It's very reactive, right, in terms of seeing how the patient responds to that. Potentially in the future, we can try to run a diagnostic and determine, okay, well, I know none of these drugs are going to be good for that patient. Maybe let's just go straight to drug D based off of their genetic differences. And so you'll see more of that as we go forward. We can do this already for things like warfarin, where we can detect certain polymorphisms and how they metabolize the drug, and we know if we need to give a lower starting dose or a higher one potentially. So we'll see that in the future. Okay, so briefly I want to go over a case kind of illustrating some therapeutic drug monitoring concepts here. So we mentioned the drug digoxin. It's frequently used for things like atrial fibrillation or CHF more commonly, and it has a therapeutic range of roughly 0.5 to 2 nanograms per ml. So it really doesn't take a whole lot of digoxin in order to get its effects, very low blood levels here. And so we have a patient who's been on the same dose of digoxin for about 15 days or so it's been about 2 weeks, and they come in, and again, without knowing the half-life of digoxin, we can assume, okay, it's probably a steady state, right? So let's just make that assumption there. And they come in, and they have a plasma level drawn the morning of our visit, and it's reported as 3.4 nanograms per ml. So initially, right off the bat, what are you thinking? Too high, right? Level looks too high. So what do you want to do now? You want to jump to decrease the dose? Anyone else agree? Okay, what if they just taken it? That's interesting. Interesting thought. the right thing to do is to put on your detective caps and decide, okay, let's go down and actually ask some questions. Like, let's try to get some more information on what's actually going on here. And we want to consider, though, what are some reasons why we might have an elevated serum concentration? Why do you think we have a high level of digoxin? Say it again? So maybe they have a low clearance of the drug, perhaps, or maybe the volume of distribution has changed to affect the clearance. That could be one reason. Absolutely. What else? You can't get rid of the drug. What else could be happening? Yeah, maybe they're taking too much, right? Maybe their dose is too high, right? That may be another reason why they would be elevated, right? Anything else? Okay, maybe they're taking it like, yeah, maybe they're taking too close together. Like if they're taking it twice a day and they take it like at 9 a.m. and then 12 p.m. And like you said, take it twice a day. You didn't say when. We assume they would take it roughly 12 hours apart, but again, your patients may not be thinking the same thing as you are unless you ask them. So there's a lot of reasons why these levels might be off. The questions you want to ask next are going to be, one, when was the dose taken last? So again, very frequently, especially when I get these tox cases that come in, patients, especially not intentional overdoses, but maybe an unintentional overdose. Patients may have differences in clearance and they come in levels too high. The biggest thing to ask is, like, when's the last time you took a dose? Was it yesterday or today? Because that makes a big difference in terms of, you know, where the level's at in terms of clearance, right? When was the blood drawn? You know, you may assume that level was done this morning, but maybe it was done last week when they went to Quest, right? So again, you have to get that context of when the level is actually done there. And then what's the dosing regimen? Have there been any changes? So for instance, if it's someone getting digoxin for their CHF and you're their primary care person, were you the one to start that digoxin in the first place? Not necessarily. It could have been their cardiologist, right? So again, unless you know, maybe their bottle says one way to take it, but then their cardiologist called them up and said, hey, take this differently. Take a half tab twice a day instead of a whole tab, right? That may not be reflected on the bottle there. So you have to ask questions like, have there been changes recently that you've initiated that may be the result of this level here? And then ask if they're having any adverse effects, right? The level's high, then presumably they're having toxicity. And by knowing the drugs, you're going to know common side effects associated with these things. So for instance, digoxin is kind of unique because it causes what we call a condition called xanthopsia. You know what that means? Opsia probably refers to eyes, right? So someone with vision. And xanth, X-A-N-T-H, means yellowing of the vision, basically. So xanthopsia means yellowing of the vision, and they'll get these kind of yellow-green halos that will show up around lights, right? Or they'll complain of nausea and vomiting associated with that. And so because knowing the common side effects of those drugs, you can say, hey, are you experiencing any of these things? And if you are, then that could be a result of the high levels there, right? So remember, when looking at this, we cannot affect the bioavailability of the clearance so much. That's going to be more patient dependent there. But the dose and the interval are something that may be more at play here, as you're going to see there. Now, for a high level, is there any reason why the patient might be absorbing more than average drug, you think? Probably not. You know, there's not really a lot of cases. Maybe if there was like a food interaction where they were absorbing it much more quickly or to a greater extent, that could be a case there. More often than not, if you have a low level, that's when you'd be more concerned with bioavailability. Maybe something who's binding it in the GI tract or something like that. But the dose, is there any reason why the patient may be taking more than prescribed? All the time, right? You know, patients, especially older patients, they have cognitive decline. Maybe they forgot that they took a dose that morning, so then they double up inadvertently. A lot of reasons for that, right? How about clearance? Why would the clearance have changed? Yeah, kidney function can go down. We see that very frequently in patients like in nursing homes where they end up getting an infection. No one's really watching them that well. They don't look at their PO intake and they get dehydrated, right? That has a direct effect on renal function, okay? What else? The hepatic function's gone down potentially depending on the drug. You know, so there could be a lot of reasons for that. And then how about the dosing interval? Why could that have changed? Like I said, maybe they're taking more often than they should. Maybe there's a change in the order that you're not aware of, right? That someone told them to take it differently. What if their level's too low? Yeah, maybe they're forgetting to take doses potentially, right? And they're taking it too infrequently. So again, depending on the case there, you can try to tease out some of that information from the patient. So anyway, other things you could look at, could there be an assay error? Potentially, yeah. And actually in some cases for critically ill patients in ICU, they can actually produce proteins that look a lot like digoxin that actually will trip the assay. So you can have patients who are not even on digoxin, they could have a positive assay there, right? So there could be interference there, which you'll learn about in particular cases. Or is there an interfering substance, right? Could there be a drug-drug interaction, drug-herbal interaction that could be a result of this high level here, right? So these are all questions you want to think about. Okay, so now what? Kind of thought through all the different issues here. Well, one, we want to confirm the sample time. So again, if you want to call the lab, call them up and say, hey, when was this actually done? Or call the nurse potentially if it was a nurse who drew the level, say, hey, when was this actually done? Determine patient adherence. So again, we use that teach back method to make sure they actually are taking their dose. Now again, if you ask a patient, hey, are you taking all your doses? They'll probably say yes. But you can ask them things like, well, what do you do if you ever miss a dose? And they're like, oh yeah, I do that all the time, and I go ahead and I just double up the next day, right? You can ask some questions like that and try to tease out what's really going on with the patient there. Assess for those concomitant other substances like herbals and other drugs. The question is, if you think the sample is wrong, you can always repeat it, right? You can always get another level done to see if it confirms what you found with that first one. That's reasonable as well, especially if the patient's not having any direct toxicity. And then, of course, we can always look at things like the renal function. We can look at the bioavailability to determine if there's any changes there. So again, do we have an appropriate indication to check the digoxin level? Sure. If we just started the patient on a dose and spent 2 weeks, that's a reasonable time frame to go ahead and check a level to make sure they're within that range, right? Obviously, they had come back and they're already experiencing toxicity. That would be another adequate reason to go ahead and do that. But again, we want to make sure that we have an adequate indication, which we do. We want to make sure the timing is appropriate, and then we can rationally interpret that level. And again, not just seeing a high level and saying, well, let's drop the dose, or let's take it less often, but make sure we're actually adequately interpreting it. And so here, again, an adequate indication would be if we had suspected toxicity, if maybe we just newly initiate treatment, what this case would be, or perhaps if we had a change in dose adjustment with, say they have renal instability, right? So there's been a change in renal function, we change the dose, we want to check a level there, or just a high-risk patient, right? When I say high-risk, anyone know what that means? Yeah, sometimes you get a feel for these patients where you're just like, you seem like a high-risk patient. Like maybe their cardiovascular status is not super stable, their renal function is not really stable. They're just likely to change their physiologic status from, say day to day or moment to moment. And so you get a feel for those patients there. And those are ones you maybe want to have a higher index of suspicion to get a level on potentially. And again, looking at this, do we suspect a drug interaction or maybe overdose? Kinetics of the drug has changed, or if we're deciding, hey, do we even want to continue therapy, right? So sometimes you can get a level for a patient, they're not getting any benefit from it. You check the levels and within the therapeutic range, you're like, okay, well, do I even want to continue this drug? Potentially, no. If they're not getting any benefit at the therapeutic range, maybe it's not the right drug for them potentially, right? So these are all good reasons to do so. And again, interpret the drug concentrations appropriately. If the level is it at steady state? You'll be able to find that out by knowing the half-life of the drug, right? Roughly 4 to 5 half-lives. Make sure it was not drawn too early. Make sure you're looking at the sample timing, the adherence of the patient. Look at the timing between the dose and when the sample is actually collected there, right? So you have to know when the dose was last given in order to make that interpretation. And then obviously, looking at things like the blood sampling site. I can't tell you how many times we've gotten a level for vancomycin that comes back. I mentioned the therapeutic range is like between, say, 15 and 20, 10 to 20, and the level comes back at 80. And I'm like, something weird's going on here. And I asked the nurse, where did you draw the blood from? And like, oh, I drew it from this IV line. I was like, it's the same one that the vanco is infusing through? And they said, oh, yeah. But really, they were measuring the vanco that was infusing through that line, not necessarily what was in the patient at that time, right? So little things like that you have to think about. Okay, if you see a level 80, I'd be very concerned. But by doing that sleuthing, you say, okay, well, maybe we just need to repeat a level, hopefully in a different line potentially, right? And then, again, you just know different patients are going to react a little bit differently. And that can all be very dependent on their kinetics, their pharmacodynamics, a lot of different things. So some reasons why levels don't make sense. Well, maybe the wrong dose was given, or maybe the infusion rate was wrong, and where the patient got way too much drug or way too little drug, depending on the case there. Maybe a dose was skipped or the infusion was held. Could be another reason, right? Why do you think a dose might be skipped in the hospital? Or the patient had to go to surgery or had to go down for an MRI and it took extra long. There's a lot of reasons why doses may be missed. You need to be aware of that, right? So that way if the level comes back too low and you're like, well, they should be a steady state. Let me make sure they got all of their doses. And if you see one that got missed, then you may say, okay, well, maybe this isn't a real steady state there. Cases where the dose was given at the wrong time, but the blood was drawn at the right time. So maybe the nurse was late or early giving the drug, but the level was drawn when appropriately. That could be a reason why the level doesn't make sense. Or the dose was given at the right time, but the blood was drawn at the wrong time. So for instance, that case there where I was trying to get a trough level, but then the nurse measured it right after the dose, and it looks like it's an actual peak now. Those are things you want to take into consideration. So as I mentioned, sample taken through the administration line is a no-go. Obviously that's incorrect because the level is going to come back too high. Do you think samples are ever taken on the wrong patient? Occasionally. It's not super common, but they'll have a patient where they're getting vancomycin and the level comes back 0. And you're like, well, it can't be 0. Obviously the nurse must be giving the drug, right? You can't just have that good of kidneys and are clearing it all. But remember in the NICU where they put baby A in bed B and baby B in bed A? Things like that can get screwed up more frequently than you might think, right? There could be sampling handling issues where if the tube was, let's say the level was supposed to be kept on ice after it was drawn and they kept it at room temperature, that can affect it potentially. Or if it was in that wrong collection tube, as I mentioned, right? So you put something, a blood sample, you want to check the coagulation into a heparinized tube, that's obviously going to screw it up. Or if I put a lithium level into a lithiated tube, that's going to screw it up. And then looking at this, does your patient fall outside of the kinetic ranges that you would normally expect for an average population? That could be a possibility. And then, was the sample drawn prior to steady state? Obviously, that would lead to falsely low levels and would prompt you to increase the dose, but that would be inappropriate, right? And then looking at this blood drawn at inappropriate time based on drug pharmacokinetics. So one thing to note here is that some drugs have what we call a distribution phase, where it actually takes a bit of time after they're given into the system for it to partition out into those tissues. Sometimes that can be 4 to 6 hours in some cases there. What we're going to find is that digoxin is actually one of those. Lithium is another common one, but you'll learn about those examples as we go forward in Pharm.1 and Pharm.2. Other things to consider was the wrong drug assayed. There's a lot of drugs that look alike and sound alike in terms of their names, and so you may find, they say to get an aminoglycoside level in this patient there. I could refer to 3 different drugs, and if you get the wrong one, sample may come back negative, right? As I mentioned, there could be interference with endogenous substances, like those critically ill patients. They produce digoxin-like compounds. That could be an issue there. Or if the storage issue in terms of the lab, if they stored it incorrectly or they was sitting there for a prolonged period of time. And then just technical errors with the lab as well could be an issue. Right? So as far as the case resolution here, digoxin actually has one of those 6 to 8 hour distribution phases. And so by knowing when the drug was given and when the level was taken, you can find out if the level might be falsely elevated, right? So again, after you give the dose, it'll sit there in the blood for a while until it has time to partition into those tissues. And so you find out that the patient took the dose at 2 hours prior to sampling, which obviously you're in that pre-distribution phase. And so you'd say, okay, well, obviously the level looks falsely high. Let me go ahead and recheck it, say 6 hours later, and it came back within the therapeutic range. Okay. Now, again, you wouldn't know this right off the bat, but again, if you get used to dealing with these drugs, if you work in a cardiology office, you're going to know this. And so ultimately, what was the intervention we needed? So hurry up and stop doing stuff, right? As they say. So no intervention is actually needed in a case like this. Versus if maybe we had rechecked the level and it was still high, then you may want to do something at that point, right? So anyway, so that's roughly a brief guide to therapeutic drug monitoring. We'll talk much more about this in detail when we get to talk about the anti-infectives. We'll talk about aminoglycosides and vancomycin and how we monitor those, and it'll illustrate a little bit more concrete examples of how we do this and what we do, and et cetera. Okay. Any questions on that? If not, take a 10-minute break. We'll come back and then start the last section. All right. Any questions from the first half? About therapeutic drug monitoring. I know there's a few questions on here. If you're already checking the blood to monitor warfarin levels, why wouldn't you check CO of warfarin instead of C0 of warfarin instead of PT-INR? That was you. Yeah, so we kind of answered that. So again, when you have a more direct measure of exactly how well the drug is working, you want to monitor that if you can. So that's why we do PT-INR. That's a direct measure of how long it takes for the blood to clot through a specific pathway, and much better ability to tell us how well warfarin's working than just looking at a level in that case there. And then we'll be posting a final study guide. No, I will not be posting a study guide. However, if you have review questions or questions at the end, I'm certainly more than happy to entertain those. As far as practice questions go, I would suggest finding a buddy to study with. Everyone has a buddy to study with, right? Yep. And going through and just change the weights of the patients we already did those calculations for, right? Again, it's the same thing every time. It's just a matter of getting that practice there. So change the weights of the kids, you'll get a different dose, and work that out with your partners, and that'll help you out, right? So very straightforward stuff we're dealing with here in terms of that. Just practice a little bit. Okay. Anyway, getting back into this. Okay, so this is kind of a wrapping it up sort of section here and a little bit about prescription writing towards the end. But basically, when we're prescribing, hopefully you're all going to be rational prescribers, correct? Not just irrational saying like, here you go, morphine for everybody, right? No, of course you're not. Right, so think about like once you make your diagnosis, there's a lot of options that are available to you. You have things like radiation, surgery, etc. However, what's most common in a lot of cases? Drugs, as it turns out, right? Very, very common for that to occur, and it very likely requires a prescription. Now, if you, as a patient, go and see a provider and you're feeling sick, you feel bad, and you go and they say, okay, well, you have a virus, there's nothing I can really do about that. See you later. You're not going to feel very good about that encounter, right? You're going to say, I wanted a prescription. Why didn't I get a prescription? It's a frequent complaint you might have for some of your patients. However, there's not always the right reason, right, to prescribe something just because someone expects it. And so we'll look at some ways to get around that. But again, most of the time when patients go to the provider, they're going to get a prescription for something, right? At least one prescription for the most part, you're going to see that. And what we're going to find is when you decide to prescribe some of the stuff, you need to have a stepwise approach to do this. So just like when you perform a physical exam, you have a stepwise approach that you perform, correct? Hopefully you don't just like say, I'm going to go check your belly and then let's go ahead and check your head. And like you go head to toe in a lot of cases, right? You don't just go do things randomly, right? Why do we do things in a set order every single time? So you don't forget stuff, right? Doing it the same way every time prevents you from forgetting stuff. Same thing here, right? We're going to go through a stepwise approach you should be trying to use when you prescribe. Anyway, once you make your initial diagnosis, right, because that's your specialty is getting the diagnosis down, and that's where the drugs now come in order for the treatment there. Again, patients want you to do something, but that's not always going to be most appropriate, right? Again, writing a prescription for a patient just to satisfy them leads to things like unnecessary cost. You get more things like antimicrobial resistance. That's a big problem why every patient coming in with sinusitis getting a Z-Pak is inappropriate, because we see a lot of that's viral, and then we see that azithromycin becomes more resistant as time goes on to a lot of those bugs, right? More adverse reactions too, right? Why introduce a drug if a patient doesn't really need it? However, once we have our tentative diagnosis there, then we can move on to the next step. So, for instance, let's say we have a patient who has probable rheumatoid arthritis, right? We've done the laboratory test, we've done our exam, we think the patient has RA. RA is an autoimmune disease that involves a lot of inflammation. We're going to see how that's important in just a moment here. So, you need to consider what the pathophysiology of the disease state is in order to make a rational decision on how to treat that, right? So, for instance, with RA, you're going to learn that it's basically the body's attacking itself, particularly with the joints. It's an autoimmune condition. There's a lot of inflammation. So, how do we treat that? Well, to treat inflammation, you give anti-inflammatories, right? So, we're going to see that will kind of guide us into choosing what kind of drugs we use in order to treat those different issues associated with RA, right? And again, education is really important here in terms of like educating patients on what their disease state is. Again, you have to make sure you're teaching to the patient's level, right? So again, a lot of patients don't have nice graduate degrees and they're very smart individuals. Sometimes they have just a high school education or less. And so you need to be able to tailor your education to speaking to someone who has almost no medical knowledge, right? Anyway, you need to select an objective for your patients in terms of what you're going to hope to do for them in terms of their disease state with medication therapy. And so looking at the pathophys, you can kind of come up with ideas for what do I want to actually manage with this? What are the goals I want to hit? And so one, the patient's in a lot of pain. Well, I can relieve pain by reducing that inflammatory process, right? And then another thing you may want to do is trying to assess or trying to arrest further disease process, right? A lot of these patients develop sort of debilitating joint damage over time, and if we can slow that down, that's going to be a benefit to the patient in the long run. Those are kind of two goals I'd want to be shooting for, and I may need different drugs in order to achieve that, right? You may need drugs to treat the acute issues, and then also drugs to treat the long-term issues, as it turns out. Don't get bogged down in the example. We're going to cover this in much more detail in the following semester, so don't worry about that. But once we decide our goals, then we want to say, okay, well, let's look at the considerations here. What might affect our dosing, what drugs we pick, etc. And so we can look at things like our other disease states. We can look at things like their age, other medications. For instance, one of the drugs I might use for RA is a corticosteroid, right? I might use steroids to treat this patient, and that's going to raise blood sugar. What if they're a diabetic patient, right? These are considerations you have to consider, that maybe I'm going to worsen their other disease states by introducing new medications in order to treat this one, right? Think about things like, we use a lot of NSAIDs like ibuprofen or naproxen in order to treat this inflammation. Well, do they have a history where maybe they can't receive these drugs? Maybe a history of GI ulcers that may predispose them to toxicity. Maybe cost is a major issue for these patients, right? You may have the best drug in the entire world to give to the patient, but if they can't afford it, guess what? they're never going to fill it, right? So just because, you went out to dinner last night at Ruth Chris and you got this really nice juicy steak and they told you all about how wonderful this drug is, you're like, I'm going to prescribe it to all my patients, and then you get into the office and they're like, I can't afford this. It's way too much, right? Or you'll say, hey, I'm going to give you samples for a couple weeks, and then you fill the prescription. They're like, holy cow, this thing's like $300. I can't afford that. Consider that stuff, right? If you have cheaper stuff available, maybe that's better for your patient. Just depends. Also think about things like the dosing strategies. Is it once daily? That's always going to be beneficial. Are there combo meds that you can prescribe to help with the compliance? Those are all things you want to think about. Next, you want to determine the appropriate regimen. So you want to think about the organ impairment of the patient. Do they have good kidneys? Is the liver functioning appropriately? And this is, again, determined by those kinetics of the drugs, which is why you're going to have at least some knowledge, or at least know how to look it up for each individual drug to look at those kinetics, right? And then again, what will the patient tolerate? If I have medications where they're having to take it 4 or 5 times a day, that can be a really big detriment to compliance, right? If you think about HIV treatment back in, say, the early 90s versus how it is today, they used to have to take dozens of pills a day, several times a day. Now we just can do sometimes 1 pill a day, right? Compliance is getting better as you can use combo drugs using less frequent dosing strategies. Okay, once you decide what you're going to prescribe, you're going to give to the patient, you have to know how to monitor for it. So for instance, I'm using something for pain. How do I monitor to see how well the drug is working? How's your pain now, right? So again, if they came in before and they're 8 out of 10, and they come back in and they say, oh, now I'm a 4 out of 10, presumably the drug is working, right? Are there other things you could look at for pain? Things like functionality, right? So, okay, well, you were unable to go to work. You called out of work 2 times last week because of your pain. Were you able to go to work this week? Look at the functioning of the patient, right? So again, different things will require different monitoring. In some cases, maybe monitoring drug levels. Sometimes it's measuring lab levels of different things, but it just depends on the situation there, right? And again, you want to explain the rationale for, things like, well, why do we only use a drug for so long, right? Why do we, say, for instance, give an antibiotic for 10 days? What are some things you want to monitor for in terms of feeling better? A lot of patients, when you give them an antibiotic, they start getting better day 3 or 4. What do they do at that point? Stop taking the med. Like, I'm all better, I'm on the mend, everything's great, right? Stop taking it. They may save it for later. Why is that a problem? Bacteria may come back. There may be more resistant afterwards. There's a lot of reasons to that. And so you need to be able to explain this rationale for why we monitor certain things, why if I'm telling you to take it for 10 days, you take it for the entire 10 days and throw away the rest, things like that. And then also explain, what would be a reason to change therapy potentially, right? So if a patient maybe has a high risk for, say, GI toxicity from NSAIDs, and you have to warn them, hey, these are the things that normal adverse effects you may run into, but here are the things you really want to be worried about, and maybe stop taking. Either call us, come back in, or go to the ER potentially, right? So for instance, if they have black tarry stool, that may be indicative of what? Upper GI bleed, right? That could be indicative of them having an ulcer that's starting to bleed, and they need to stop taking that NSAID immediately, right? They have hematemesis or something. You got to let them know what the common stuff is, but also what are the big warning things they need to be watchful for. Even if it's rare, they still need to be aware of it, right? And then education, as I mentioned, is super, super important. Make sure you find ways to kind of custom tailor that education for those patients. Think about age barriers, right? So for instance, if I have a 3-year-old, you think I'm going to be able to educate them on their meds? No, they're not going to take them anyway, right? But think about if you have an adolescent, right? A 16-year-old, they want to be more in charge of what their health and things like that. You can educate them to their level, right? Think about language barriers, right? I think it's the most frequent language barrier we run into here in Orlando. You speak Spanish? No, then you're kind of behind the game in a lot of cases there, right? There's a lot of offices that our students go to, or you guys will go to, where they only speak Spanish. And if you don't, you're stuck, right? You're very much behind the 8 ball in a lot of those cases there. Now, there are resources out there that can help you. There are translation services, etc. But you never know when a patient's going to come in speaking Portuguese, or they're going to come in speaking Farsi, or whatever the case may be. You need to be prepared for that sort of thing, having services available for them. Also think about the educational barriers. You may have a lot of people who have no education past a middle school education. You may have people who are physicians you're treating. Like, you need to be able to custom tailor it to them. And use educational materials if you can, right? So things like Lexicon, which you found, you can print off patient education right from there. A lot of resources online that you can use. So as an example, here's a drug called Diastat. This is actually a rectally administered drug for seizures. Why do you think we use rectally administered drug to treat a seizure? Can't give anything orally, right? Because again, they can choke on and aspirate on it. So this is a drug. Obviously, the patient would not be giving it to themselves because they're actually having the seizures. But if you're educating, say, a parent who has a newly diagnosed child with a seizure disorder, and you say, okay, well, here's how you use this medication here. If you don't educate them appropriately, and all of a sudden the kid's having a seizure, they're on the floor, and you're supposed to give this medication rectally, How do you think their apprehension level's going to be doing? Be pretty high? Anxiety is going to be riding up pretty high? Yeah, it probably might be close to panicking. And so by educating beforehand, you can try to make sure they are equipped with the proper tools and education to know how to respond to that appropriately, right? So that way you can say, hey, remember, when you take this drug out, to use the lubricant packet. There's a lubricant packet that comes in there, so when you insert it rectally, you don't cause rectal trauma. They may forget that step if you didn't educate them on it beforehand. They may still forget it anyway, but at least you did your due diligence, right? And can you always assume the pharmacist is going to educate them? No, a lot of times they're busy too. And so, again, you want to make sure you're not that hole in the Swiss cheese, right? You want to make sure that you're going to be the one to make sure you educate them. If they get double education, great. If not, at least you were the one person that did it, okay? So don't assume everyone else is going to explain it to them. Okay, so let's go through an example here. Let's say we have a 3-year-old that presents with left ear pain, they have a fever of 101.3, and they have cough and runny nose. You take your handy dandy otoscope, and what do you see? See that. Does that look normal? Not normal? It's pretty mad, right? So what do we think? Probably having acute otitis media, right? So very classic textbook case there. So obviously you're going to make your diagnosis, right? You're going to say, okay, I think this is an acute otitis media here. And then obviously when you make that diagnosis, explain it to the patient. Like, why do you think it could be this? Right? What do you think is causing this? Is it bacterial? Is it viral? What do you think it is, right? And so you want to think about the pathophysiologic implications, right? So what are the most common things to cause acute otitis? And based off of that, what is my drug therapy going to be for that? And so we're going to talk a lot about bugs and drugs next semester. And that means that when you have a particular disease state and you think, hey, I think this is a pneumonia, here's the most common bugs to cause that. Thus, I'm going to use these antibiotics because these are most likely to cover those bugs, right? We're going to talk a lot about that next semester. But for an instance here of acute otitis media, I know that things like strep pneumo, H. influenza tend to be most common. So I want to obviously use an antibiotic that's most likely to cover that, right? Could it still be viral? Sure, but more often than not, it tends to be bacterial. And so because of the odds, we say, well, let's go ahead and treat in this case here. Right? We want to make sure we're using appropriate antibiotics because if we use things that are inappropriate, that's where you can see that resistance start to develop there. Again, you're educating along the way. Say, hey, listen, I'm going to go with this antibiotic because I think it's going to cover for the bacteria that's causing your child's acute otitis media.
Question.
Yes.
Because, antibiotics are overused.
Yes.
Right, in general. So before you actually give them antibiotic, wouldn't it be safer or better to actually test them whether or not it's bacterial or viral? Or is it not always possible, I guess?
Yeah, so it's not always possible, right? So you have to think about the clinical situation. We'll talk more about this later, but it depends on a lot of factors. So for instance, is it easy to culture an acute otitis media? Not really, because you have to get behind the tympanic membrane to do that. Potentially, if the kid has tubes in place, like they've had recurrent otitis before and they had tubes placed, you can sometimes check. Yeah, you can sometimes test the drainage to do a culture there. But a lot of times, if something is very common and we know oftentimes what the most likely bugs are, we can treat empirically, right? So without having a culture, you can say, okay, let's just go ahead and treat this, and then we'll see if the patient gets better. If they don't, then obviously we may need to do further testing, right? Also, you can get a culture, but then you want to treat with something in the meantime if you think it's bacterial, because otherwise the kid's going to be miserable the entire time, and that infection could worsen, right? So little things like that to consider. Certain things we'll go ahead and just start treatment and we'll get a culture at the same time, and then that way if it comes back and it's resistant, then we can change that up. So we'll do a lot for like UTIs, like a strep pharyngitis, things like that. Anyway, so you want to consider your resources and trying to find out about this stuff. So for instance, the CDC is a really good resource for a lot of things infectious disease related. You can either refer your patients out to that to read that up on that, or you yourself can educate yourself on it. But then we want to select a therapeutic objective, right? So obviously our goals, for one, should be to get rid of the bacterial infection. That's always going to be the appropriate thing to do. We need to make sure we're using appropriate antibiotic coverage, though, right? We don't use something that's too weak to cover the stuff we think it is. And we also want to make sure we're not going with such a broad coverage that we get resistance and get all kinds of other problems, right? We want to treat that. We also want to treat the other sequelae of the disease, including things like the fever, right? The kid had a 101.3 fever, probably feels pretty miserable. How can we manage that? Tylenol, ibuprofen, right? So again, you're going to come up with a list of drugs I think are going to be recommended for this patient based off of this. Now, the antibiotics is going to require a prescription. What about the Tylenol and ibuprofen? No, but you still give them information on how much to take, when they should be taking it, et cetera, right? It'll still be part of your recommendations there. And then we want to look at the drug of choice. We'll take into account the age of the patient. Sometimes for infectious disease, the age of the patient will change what antibiotics you use. For instance, if you have meningitis and you have a baby who's just born past 28 days, they get a different cocktail of drugs than it would be if they're, say, a year old versus if you're, say, greater than 65. Look at the organ function, look at the allergies, right? If they have a penicillin allergy, that's going to definitely affect us here. And then also look at previous and current medications, right? So especially with antibiotics, why do you want to know about previous antibiotic use?
Works for them or is it allergic as well?
Or maybe if they were on it for an acute otitis media before and they've gotten the same drug 3 or 4 times, perhaps this drug is now resistant, right? Maybe you need to switch up to something else. Maybe you need to expand your coverage a little bit. So those are things you want to consider there. And obviously you had to know your resources to know what appropriate medications are. So for instance, with drug references, we mentioned LexiComp, which you find through UpToDate. It's a very handy reference there. But things like Micromedics might be available. There's another one called Clinical Pharmacology. It really depends on where you work and what they have available for you. And you'll notice, and again, I don't work for Adventist Health in the hospital, so I don't know what they use typically, but you'll kind of get used to that wherever you end up at on rotations and working. Other things you want to consider, though, things like the Sanford Guide. That's an infectious disease book that's really handy if you get a copy of it. It comes out every year. And you can look up, based on disease state, hey, I have a kid with pneumonia. What's the most likely bugs, and what drug should I use for that? It's a very handy tool for that. There's even a book just for pediatric infectious disease called the Red Book. Short of that, those are standard references. Well, I can also look for practice guidelines, right? Usually these are the most up-to-date recommendations from experts saying, here's what we think are the best drugs to use for this particular indication here. So as an example, for anything infectious disease, the IDSA, or the Infectious Disease Society of America, has a lot of really good guidelines out there, right? Or the American Academy of Pediatrics has a guideline for acute otitis media, which is appropriate for this 3-year-old, right? So again, know your references, know your resources when you're managing these patients. Or you could always look at what? UpToDate is also very helpful, right? So again, it's always a good reference if you have the availability of that. So things to consider: how often is the drug given? If I have to give a kid a drug every 6 hours, is that going to be very handy for a 3-year-old? No, I'm going to get a lot of drugs spit out on me. So if I can give something once a day, that'd be nice, right? So fewer times you have to administer it, the better. What kind of dosage forms are available? Can you give a tablet to a 3-year-old? Chances are no, right? So are there liquid preparations that are available? If not, they can't tolerate PO, what could I do instead? Maybe I have to give, well, if I don't have any rectally available antibiotics, what can I do instead? Sometimes you use a parenteral, right? Sometimes I'd have to use something like an intramuscular injection potentially, right? So again, just depends on the situation there. Eardrop's not quite as good for an acute otitis media because it's a hard time penetrating there. So, but if it's like an otitis externa, or if that tube's in place, then you could do that more likely. But the question, how much does it cost, right? Do they have insurance to cover this? Are they coming in from out of the country and they're having to pay out of pocket for this stuff? Are there free antibiotic options, right? So if you go to Walmart, or if you go to Publix and places like that, they oftentimes have cheap or free drugs. Why do you think they do that? I'm going to go buy the stuff, right? So again, if you come into Publix and you give me a script for amoxicillin and I say it's going to be 45 minutes, probably doesn't take me that long to actually do it, but then you're going along, you get some rotisserie chicken and a pub sub, and you get some other stuff, and all of a sudden you spend $200 at Publix for the free antibiotic. They've made their money, right? So again, those are things you want to consider. But it's a really good option for those patients as well, right? Again, free antibiotic is still free antibiotic as it turns out, okay? And then how palatable is the medication? When I say palatable, what do I mean? How's it taste, right? So again, oftentimes we'll have flavoring options at the pharmacy, but if something comes and it's just a nasty cherry flavor, then that may be your only option there, right? Yes, sir.
So I used to work in a nursing home, and they would, like, sometimes when, like, the patients, they wouldn't take their medication, they would just crush it up and put it in their, like, their pudding or something.
Yeah.
So is that, like, an option to throw it into, like, is that, like, a recommendation?
Yeah, potentially you could do that. So there are certain things you don't want to crush or chew because usually they're like an extended release preparation, right? So there's a list of that stuff you can find, but that's another alternative. We'll do that sometimes, like say for instance we have a kid who's on a ketogenic diet. We don't want to give them all the sugar that's in a lot of those oral preparations, those liquids. We'll crush up a tablet, put it in water. Or for instance, if we have someone who has a G tube or something, we'll just place it in water and go down the G tube, because then at that point palatability doesn't really matter because they're not tasting it. You know? So there's different options there, but yeah, if you can crush it, put it in applesauce, that may be a good option. Yep. So anyway, so looking at this is actually a table from one of the guidelines for acute otitis media, and it's really nice because they tell you basically in black and white what exactly to use for your patient here. So recommended first-line treatment here, amoxicillin 80 to 90 mg per kilo per day in 2 divided doses, or you can bump it up and use amoxicillin clavulanic acid. This is Augmentin. This is Amoxil. I'm curious about the brand names there. And again, using either one of these is totally fine, right? Or what if you need to do something different? What if they had a penicillin allergy? What could you use instead? And they'll give you options for that as well. So again, follow your guidelines, because again, when someone comes back and asks you, hey, why did you treat this patient this way? You don't want to just say just because. You want to be able to say, well, I followed the guidelines, right? I followed a protocol here, and it said to use amoxicillin 90 milligrams per kilo per day divided twice daily, right? Anyway, so once we select our appropriate dosing regimen, we are going to go ahead and go with amoxicillin suspension for this child. It's 90 mg per kilo per day divided twice a day. Suspension comes as a 400 per 5 milligram solution, and the patient weighs 20 kilograms. So how many mLs do they need per dose? So this is another one of those math problems you should be able to figure out for the test, right? So let's work through it. I'm going to bring up my calculator too. I know it's on the next slide, but don't cheat. Just do it with me, right? So question is, well, how much are we going to use for this patient? How much in terms of drugs should they get per day? So per day, how do I do that calculation? What do I do? Weight times the total daily dose, right? So I do 20, again, apologize for my handwriting here, times what? 90, right? So that equals how much? 1,800 milligrams per day, right? I'm not going to draw the units, but you get the sense for it. So that's 1,800 milligrams per day they should be getting. So then I'm asking, okay, well, that's per day, but how many times am I giving it? There it says divided twice daily. So now what do I do? Divide by 2, right? So I'm going to get 900 milligrams per day, right? Or per dose, yeah, I'm sorry. See, even I can make mistakes sometimes. So we take 900 milligrams per dose, okay? Now what do I do? Yeah, so I'm going to go ahead and figure out my solution, my concentration of the solution, or the suspension here per ml. That turns into what? Right, so this is going to be 80 milligram per ml solution. Very good. And then what do I do at this point? I'm going to take that 900 and divide it by 80. That should give me my mLs per dose equals 11.25. Okay, now could I round that? You probably could, yeah. I mean, you can probably measure to 11.25 on a dosing syringe, but if you want to measure down to 11, that's fine. 11 and a half, you could say that too. You know, again, with the 10% or so, you're totally fine there. So again, I'll have an exact, I'm not going to have like any rounding on there really. It'll be pretty straight. It'll be to the 10th place, I think, is the most extreme I get there. But yeah, I'm not going to give you, the math is designed to be fairly straightforward in that regard. I don't want to, if you got something wrong, like writing those kind of questions is really tough because it's like, how do you write appropriate distractors? And usually have to do it to where it's like if you missed a step or you forgot to do something, that's usually where you goof up, right? That's where usually what the wrong answers are for the most part. So as long as you follow all the steps and you keep your units straight, and you ultimately look like what should my ultimate end result be if the dose is in mLs, if all the answer choices are in mLs, then how do I get to there, right? So using your endpoint to backtrack that to say, well, how do I get to this point here, okay? So follow your units, and you can't really go wrong with this stuff, okay? Anyways, does that make sense for everyone? Fairly straightforward. And guess what? This is like all PEDS dose calculation for the most part. It's like 99% of it. If you can do this, you can do fluids, you got the majority of it. But a lot of people feel very apprehensive doing this when they first initially try it out, and so that's where a lot of that's what I'm trying to build up your confidence. And so you'll probably have a PEDS dose calculation on probably every single prescription writing assignment from here on out. So you'll get very comfortable with it by the time you go on rotations. Okay, we do different types of dosage forms and things like that, but you'll be fairly comfortable. Okay. And again, 11.25 is what we've initially or finally got as our answer here. Okay, so then we want to figure out our plan for monitoring for this patient here. So you should be able to describe what the common side effects are. So as an example for antibiotics, what do you think is common? Nausea, vomiting, diarrhea, right? Messing up the gut flora, you can see the diarrhea associated with that. This is very common. Explain what the common things are you want to look for, and then also what are the really dangerous things that are rare, but you should be aware of. So if their lips start to swell and their tongue gets big, that should be a big warning sign, right? You should go to the ER immediately for that sort of thing. These are things you want to let them know about. It's rare, but you still got to let them know so that way you can say you educated them. Also, if it says take it for 10 days, explain to them why they need to take it for 10 days. Your child may be feeling better, and if I don't have to give any meds to my kid, that's always a win, but they need to give it for the full course because otherwise you can lead to that resistance there, right? And again, explain what would constitute a change in therapy. When would you need to come back and see the provider again? Is it because the patient's not getting any better? Could it be because they have an allergy? Things like that is you want to let them know when to follow up with you, right? And then plan for that education. Try to, for instance, if you go in LexiComp, you can find very easy Spanish instruction for the patients, which is really nice. There's translator services. All of that is very beneficial to help you make sure your patients are educated. Okay, so moving into the prescription writing, who can write prescriptions? MDs, DOs, who else? NPs, PAs, dentists, optometrists, vets, right? There's a lot of people that can write prescriptions. Can pharmacists? No, we can dispense them, we can't fill them, or we can't write them, right? Not to say I've never written a prescription for a doc and had them sign off on it, right? But again, they cannot be the one that actually signing off on that sort of thing. So a lot of different people here, and it's important to know who can write these prescriptions. At least for my end, especially when my short stint in retail, I'd have orders come up for really odd dosing for medications. One time I remember filling an antibiotic for like a huge amount of Keflex, which is an antibiotic. I'm like, there's no way anyone on earth is this big to require this much Keflex. What is going on here? And then I asked the patient, I was like, who's this for? And they're like, oh, it's for my dog. They're Burmese mountain dog. Okay, that probably does require a lot of Keflex there. So again, sometimes you get kind of the oddball sort of prescriptions there. Anyway, in general, a good rule of thumb to remember when looking at these prescription drugs or writing prescriptions, typically when you have state and federal laws that are competing with one another, you typically go with whichever one is stricter or more strict, right? So again, if something says you can only write for 3 days worth of a drug, and then something else says you can write for 5, go with whichever one's more strict. And that way you'll keep yourself out of trouble in terms of legal versus federal laws, okay? If it's not addressed in state law, then just go with the federal law. And I'll talk about some examples where this comes up soon. Now remember, prescribing errors are frequently common, or very, very common. You're going to find that these need to be legible and unambiguous. When I say unambiguous, what does that mean? You should be very clear in your instructions that anyone reading it should know exactly what your intentions were, right? They should know exactly what you're thinking when you wrote that. And again, it should have enough information to catch any errors that you might have included on that. Now, are you ever going to write a prescription with an error? Of course not. No, you're going to be perfect, right? Never, ever will you do that. But on the rare off chance, the stars align such that you write an error, then someone else should be able to catch it. Now, I'm not going to go deep into the law specifically, but I want you to know what is expected to be on a prescription in order to make it valid. And this is what is a lot of it is included on your prescription assignments, because I want you to be writing valid prescriptions, right? So, for instance, if it is written or typed, it must be legible. They had to put that into the law because people have really bad handwriting, right? You need to include the name of the practitioner, the name and the strength of the drug prescribed. So again, what type of tablet, what strength tablet it is, if it's a suspension, what the concentration is. You need to include that on there so that way we know what to send out with the patient, right? We need to know the quantity of drug to dispense, the directions for use, and it needs to be dated. Now, can I predate a whole lot of prescriptions and sign them beforehand to kind of speed up my process? Should not be doing that. Does that mean no one's ever done that? Who can say? But you should not be doing that. No pre-signing prescriptions. Do they have to be a handwritten signature?
No.
It can be a stamp. It can be electronic. Yeah. So, and these are for non-controlled substances, right? We'll talk about controlled substances in a little bit. These could also be called in. They can be faxed in. Anything like that is totally fine in terms of communication of that stuff, right? And again, for non-controlled substances, they are good for 1 year. Now, you could write for, say, a month's worth of a drug and write for 24 refills. Say, hey, you're good for 2 years. I don't want to see you for another 2 years. After that 1 year is up, guess what? It's no longer valid. We're not going to fill that anymore. They have to come back to you and get another script written. Okay. Now, you can write multiple non-controlled substances onto one prescription. That's totally fine. However, controlled substances should be kept separate. And then we'll talk about C2s in a minute. Those need to be separate all by themselves, right? So basically one script per prescription there. Now here's an example, and if you look at the example in the prescription writing rubric, you're going to see this looks pretty similar, right? So again, you're going to have the name of the provider, you're going to have name of the patient. Notice here that there's some additional stuff that is not required, but is still handy to have for the purposes of making it clear and making sure we're not going to have any errors that pop up. So for instance, writing no drug allergies. That can be handy to make sure that we know, okay, the patient does not have an allergy. I don't have to worry about any kind of cross reactions there. Why do we put the address for the patient? That wasn't required. Yeah, do you think there's more than one Sean Martin in the world? Yeah, absolutely. There's a lot of John Smiths out there and all kinds of different people with the same name. And date of birth was also not required on that prescription either, but we put that on there in order to make sure that we know we're dealing with the right patient. Because again, a lot of these systems are nationalized. If you go to CVS, you can look up any patient in the entire CVS network. There's a lot of people with the same name, so we want to differentiate based on birthday, based on the address, to make sure we have the right patient, right? Using multiple identifiers. And again, they write their indication here. Indication is not required, but it is something very good to have on hand to know, like, what are we using this drug for? You know, metformin is usually used for diabetes, but it could also be used for PCOS. It could be used for a number of things. We'd like to know what you're using it for to make sure that it's appropriate, right? So just another double check that we can do there. Now, some prescribing errors, very frequently this is due to omission of information. So for instance, continue present IV fluids. Unless you know what specific fluids those are, you may hang the wrong one on the next time, right? You may need to be very specific about what you're saying in your instructions. Otherwise, people may have to interpret things, and when they have to interpret things, that's where mistakes can happen, right? For instance, if you may not indicate whether a drug is short or long acting, you may screw up the dosing, whether you're giving too much or too little, depending on the situation there. And then writing as needed, but not saying what it's as needed for, right? Some of it may be very intuitive, but for instance, you think morphine, that's obviously as needed for pain, but it can be sometimes used for cough, right? It could be used for other things as well. So always keep in mind, it's good to write more information than less in order to make things as unambiguous as possible. And again, try not to write like this. A lot of times this is being supplanted by e-prescribing, and most of you will probably do e-prescribing for most of your careers, but is there ever a chance you might write a handwritten prescription? Yeah, computers go down all the time, right? So again, there's no reason why you shouldn't be able to do very legible handwritten prescriptions. I'm about to look at a lot of yours. I expect all of them to be extremely legible, right? Hopefully. I've seen some bad ones in my day, but hopefully you guys won't take the cake. Prescribing errors. When writing your prescriptions, here's some general things I want to see done because these are going to help to reduce errors. So for instance, misplaced decimals. If you write 0.1 or 0.2, that can be easily misread as 1 or 2, right? So by putting a leading 0 there, so writing 0.1 or 0.2, you prevent that error from occurring there, right? And that could be a tenfold error potentially. It should be really dangerous. Writing unnecessary decimals after the decimal point, or after unnecessary zeros after the decimal. So writing 1.0 could be misread as 10, right? So don't do that. If it's just 1, just write 1. 2, whatever. 2.4, then you write 2.4, but if it's unnecessary after the decimal, then don't write anything. And then don't just use U's. U's normally refers to what? Units. Instead, just write 0, or that could be misread as a 0 there. So for instance, if someone wrote 10 U of insulin, it can be misread as 100 units. And guess what? That could kill that patient, right? So you got to be really careful with this stuff. So just write out units. For my purposes, you'll find some things are dosed as international units. You don't have to write the international for my purposes. Just write units and you're fine there. Okay. Other types of errors. Writing out micrograms could be misread as milligrams, which would be a 1,000-fold overdose potentially. So instead, we like to see mcg being used. Okay. And a lot of this actually comes from the Joint Commission. You guys are familiar with Joint Commission? Right, they're the ones that basically say whether you get CMS funding or not if you get accredited. So if you use a lot of these poor prescribing habits, they'll ding you for it and they'll give you some issues. So here writing MCG helps to prevent that confusion there. We also don't write QD. I will definitely ding you if you write QD. Write daily, Q daily, whatever you want to do, since that could be misread as QID. And again, on the screen here, it looks pretty clear cut, right? Like how could you misread QD for QID? But when you're handwriting it, guess what? It can be misread quite easily depending on the case. And then actually there's some abbreviations. We don't really use that frequently anymore. For instance, MSO4 was confused with MgSO4. MgSO4 stands for what? Anyone know? Magnesium sulfate. Anyone know what MSO4 was? Morphine sulfate, right? So you trying to give your patient magnesium, but you accidentally screwed up and give them morphine instead. They might thank you for it, but it's not going to fix their magnesium, right? Vice versa. So other issues that come up. One, making sure that you include the correct strength and dosage form. A lot of times pills and tablets and things will have multiple varieties of it, and if you fill the wrong one, or like for instance if you're writing for a suspension and you write the volume but you didn't include the concentration, we might fill it with the wrong one and then you get the wrong dose for your patient there. So you have to be very clear on that. Make sure you're writing out in mLs. Don't just write teaspoons or tablespoons. Anyone remember how much a teaspoon is? 5 mLs tablespoon? 15, right? 15. Just write mLs, right? It just keeps everything much more clear from a patient delivery standpoint. Make sure to include the quantity of drug. So what you write for should match up with what the quantity is. And if you're writing for an as needed, then generally how much should you write for? Quantity wise. So if it's as, so for instance, say like for instance with your Celebrex prescription, right, coming up, right? It's as needed for how many days? 5 days, right? So again, if that's needed for 5 days, it may not take every single dose, but what should your quantity to dispense be?
Max that you can take.
Right, assuming they took every single dose, right? So you want to think about these sorts of things, right? It's a little tip for free for your prescription assignment. But anyway, so think about the quantity. Make sure that makes sense based off what you're actually writing for there, okay? Now, if a drug comes as a generic, we will by law, we're allowed to substitute that in, and we do that automatically, even if you write for a brand name drug, right? Because again, it's a cost savings to our patient, and they work just as well, right? Because they show bioequivalence, so we're able to do that. There's a way you can get around that, though. If you really, really want your patients just to get the brand name, you can write DAW or dispense as written, and that will force us to fill it with that brand name. Now, why might you want to do that? Yeah, so there's rarely a case where we have to do that. Most often it's because they had a bad reaction to a generic formulation, such as, that it had a dye in it or something they had a bad reaction to. More often than not, the patients are just kind of a pain in the butt, and they're just saying, I only want the brand name, that one only works for me, and nothing you say can persuade them otherwise. And sometimes you do it for that, right? So just depends. Now again, I posted this list, should be available along with the prescription assignment. But these are things you kind of want to avoid in terms of abbreviations because they might be misread or misinterpreted depending on the case there. So again, these are things I like to avoid if possible. And again, if you use any of these, I'll probably end up dinging you. The QD is the most common one, or just writing U for units. Those are the most things I have to ding students for most often, QD. Okay, other things you might see on prescriptions, you might see take as written or take as directed. Generally, that should be avoided for the most part unless the dosage form comes in such an explicit state that there's really no other way to do it. So as an example, here's a case of a methylprednisolone dose pack, or say a Medrol dose pack. This is basically where they tell you specifically on day 1 here, take 6 tablets. On day 5 or day 2, take 5, 4, 3, 2, 1. That's very clear. And instead of you having to write out every single instruction, you can write use as directed because it's right there on there, right? Most of the time, though, you want to be explicit and write exactly how you want them to take it. Okay. Other things, you have to be really careful with your dosage forms. So as an example, if you were working in the ER and you have a patient who's coding in cardiac arrest and someone says, give them an amp of calcium. It's a frequent thing you might hear. Give them an amp of bicarb. Anyone know what amp means? Things that you plug your guitar into? No, it's a glass vial. Basically, it had a glass topper you had to snap off. It's a very old way of preparing IV meds, but we still use these occasionally. It's not very common, but these are flip-top vials here, so you don't have to worry about getting glass in your product. But amp is an old term. It stands for ampule, right? It's really kind of an imprecise sort of nomenclature, but still people have been saying it for decades, so they still say that. But by saying give an amp of calcium, well, frequently in a code situation, you have 2 forms of calcium that are available. You have calcium gluconate and calcium chloride. Both of them come as a 1 gram vial. Both are 10% solutions. Both come in 10 ml vials. So is there any difference between the two? Yeah, they're different salts. And actually, calcium gluconate only has 1/3 of the calcium that calcium chloride does. So you may have assumed that people understand you mean calcium chloride, but unless you say it, people can misinterpret it, right? So you got to be really careful with this stuff and be very explicit. Say I would like 10 mLs of calcium chloride stat, IV push stat, right? So you want to be very explicit in your instructions. Sodium bicarb is another one where if you're dealing with an adult patient, you typically use this solution here that is 1 ml equivalent per ml of sodium bicarb. It's 50 mLs versus this one is for infants, 10 mLs, 0.5 ml equivalents per ml. So if you say give an amp of bicarb and someone gives you the infant one on accident, that's a much smaller dose than what you're expecting. Or vice versa, if you had an infant you're dealing with and someone said give an amp of bicarb, and of course like you'd assume your nurses are going to be like experts and they're gonna catch any errors that you have, right? Because nurses are perfect, right? Honestly, like a lot of the ER nurses, they're probably better than some of the docs in terms of like running codes and stuff like that. Just because they've been doing it for so long. You have these like really salty old nurses that have been just doing this for like decades, and they're really good, right? Sometimes you get the baby nurses though. They're like just graduated, and they will do whatever you say. If you say anything, they'll take it for the holy commandment. Like, this is what's going to happen, and so you got to be very explicit for that kind of stuff, right? So if you say amp of bicarb, you never know what you're going to get if you're not explicit. I had one case when I was in fellowship. We were in the ER. A patient was coding, and there was a newbie nurse that was working with one of the more seasoned nurses. And she said, hey, let's go ahead and get an epi drip ready for this patient here, right? Normally for an epi drip, what we do is we take one of these 10 ml syringes of epinephrine. It's a lower concentration. We put that into a bag of fluid, and then we hang that on the patient. We also have this 30 ml really concentrated vial of epi that's also there as well. And so the newbie nurse was like, okay, I got to make this drip. She goes, oh, do I use the whole thing? That's what she said verbatim. And the nurse who was proctoring her, she was focused on the patient. And she said, yeah, you just use the whole thing. Not knowing whether she meant the syringe or the vial. Well, the newbie nurse thought it meant the vial, even though the other nurse thought she meant the syringe. So the entire 30 mLs, which was like way more than 30 times what the patient should have gotten, got into that bag. Fortunately, someone caught it before it got hung on the patient, but it's one of those things where if you're not explicit, errors can happen here, right? So again, be very, very clear on these sorts of things. Units are super important. I've seen entire vials of nitroglycerin being infused into a patient over the course of minutes because they got the units screwed up. You can say start 20 of dopamine, but you got to say, well, 20 what of dopamine? Do you mean milligrams per hour, mics per kilo per hour, mics per minute? If you screw this up, that could be a problem, right? So someone said, hey, start nitroglycerin at whatever dose, and they never said units. And so they meant mics per minute, but the person who was programming the pump put in mics per kilo per minute. So multiply that by the patient's weight, a lot more got infused all at once. The patient has a horrible headache, they're hypotensive. Hopefully did okay, but again, this is why you gotta be explicit. Other things you want to be careful of when prescribing is looking at contraindications or other interactions with the patient's meds and making sure you're asking about herbal and OTC utilizations in that case there. And again, consider, are there any kind of physiochemical compatibilities with drugs? So for instance, if they're taking calcium for osteoporosis and they take a fluoroquinolone antibiotic, those are going to bind together in the GI tract. Those are things you have to be concerned with. And then any disease state interactions. If they have diabetes, I'm giving you a medication that could increase blood sugar, that could be a problem, right? And then compliance, there's a lot of reasons why patients may not be compliant with your regimens, right? And so I'll talk about kind of these 4 main ones here. And again, compliance just means how well the patients are adhering to your instructions. And you tend to find that a lot of patients don't fill their prescriptions, right? About a third of them may not fill them. And why do you think that is? Could be money issue for sure. Maybe they feel better. Maybe they don't have a perceived need for the medication. I can't tell you when I was my short stint in retail when I was in school how many times you had people coming in from the ER that have a prescription for antibiotic for a dental abscess, dental infection, and then hydrocodone and acetaminophen, and they say just give me the Lortab, that's fine, just give me the hydrocodone. I say you don't want the antibiotic? No, I'm good. Okay, may not have a perceived need for it. Maybe they had nefarious purposes in mind in the first place, who could say? But there's a lot of reasons for that, right? Sometimes drug shortages can prevent people from getting their medications the time of day. If you don't have a 24-hour pharmacy around you, guess what? You may not be able to fill it till that next morning. And if you're in the ER at 3 o'clock in the morning, that may make a difference, right? So other things, patients may fail to understand the instructions, which can lead to wrong dosage, frequency, route in some cases. It just depends on the situation there. But again, using that teach-back method is super important to make sure they understand specifically what you're trying to prescribe to them. So as an example, if you had a patient, you said take 2 tablets by mouth twice daily, how many tablets do you think that patient is supposed to take? Say you take 4 in a day, right? A patient, on the other hand, might interpret as what? Maybe they take 2 tablets in a day twice, so I'm going to take 1 tablet in the morning, 1 tablet at night. But by having them teach it back to you, you can say, oh, well, actually, wait a second, no, you're supposed to take 2 tablets in the morning and 2 tablets at night, okay? And that way it can be more clear for them. Now, again, patients may prematurely discontinue medications. Either they feel like they're getting better, so they may not continue an entire antibiotic course, or the bottle's empty and they say, okay, I must not need any more. I realize that there's refills on there, right? Sometimes patients don't perceive any benefit, right? So as an example, when we get to the psych meds, we'll talk about how antidepressants take sometimes 4 to 6 weeks before they really start to kick in and work. If you're depressed and you're taking medication for 2 weeks and you don't see any benefit, do you want to continue taking it? Probably not, right? So by educating them, let them know, hey, you guys stick with this for a while before it really kicks in to see how it works. That way they're more likely to be compliant, right? And then they're taking the medication inappropriately. Why do you think they'd share medication with others? Save money, right? So if you got Ethel up the street and she's got some leftover Cipro from her last infection, she can give some to you. It works out, right? Taking someone else's medications, right, can be a big problem there. And then just medication abuse, right? So you have to consider, are they abusing medications for any particular purposes? Maybe they're not even taking the medication you prescribe them. Maybe they're selling them. Maybe they're doing all sorts of things with them. So it just depends. Now, getting into the idea of controlled substances. When I say controlled substance, what does that mean? It's a substance it's controlled, right? So it's regulated by the DEA, right? They say these are drugs that have high abuse potential, right? They have a high potential for abuse and addiction, okay? And we're going to control these more tightly than we would, say, a non-controlled substance, okay? So it's kind of that 3 levels. You have the OTC meds you can get any time of day. There's prescription-only meds, and then now you have the controlled substances, okay? There's 5 different schedules for these. Schedule 1 is the highest, meaning it has the most abuse potential, and there's no acceptable medical usage for that drug. It's a felony to have it regardless. You cannot have any, you can't prescribe it, you can't have it. It's illegal, right? Schedule 2 substances have a high abuse potential, but they do have an acceptable medical use. I'll give you some examples here in a second. These are going to be regulated the most tightly out of the bunch because, again, these are the ones you can actually prescribe. 3 through 5 tends to get regulated a little less tightly because the abuse potential is much less with those. At least that's perceived. And again, these are humans making these subjective judgments in terms of abuse potential, and so we'll look at some of the changes that have occurred with that over time. But they do have different prescription requirements on there, and it's important to know what those are, right? And you as PAs, can you write for controlled substances? Now you can. There's been a recent change in the past couple of years. I think 2017 is when that went into effect. And in 2018, we had the new House bill that came through and really regulated a lot on how much you could prescribe. But if you want to get your DEA license, guess what? You can do that. You can prescribe certain controlled substances. If you work in a hospital, you're working under the DEA license of the hospital at that point. You can prescribe all kinds of controlled substances, no problem. But it's important to know your regulations. When writing for a script for a controlled substance, so you want to make sure the name and the full address of the patient, or if it's an animal getting a controlled substance, then you have to make sure you have the owner of the animal there. What do you think an animal would need a controlled substance? Maybe surgery. More often than not, it's actually seizures. I see a lot of phenobarbital used for like animal seizures and whatnot. It's usually the most common one. But you would not be. I'm just saying in general. These are like the laws. That's important for ethics. So like if your patient came up and like, oh man, my dog he's got arthritis. Can you prescribe something for him? You never know. Patients ask all kinds of stuff. Yeah. Again, I'm just trying to be complete here. Just include the information. But you also want to make sure that you need to have the DEA number on there, right? So the DEA number identifies you as being registered with the DEA. You're going to include this with things like your MPI number and your license number to make sure we can identify you as a prescriber. And then the really big thing here to make sure is you write and have the numerical quantity to dispense. What do you think this needs to be written out textually along with the number? So imagine if I had a prescription, and you wrote the quantity to dispense as 10. What could I do as a patient? I can just say, well, let's just add a little something here for myself, right? So, oh wow. So by doing that, you know, that's obviously manipulating the prescription. It's no good. So by writing 10 TEN on there, you would be able to much more accurately say, okay, this patient should only be getting 10. If I saw that they tried to modify it, then I would say I'm just not going to fill that, right? Because as a pharmacist, I can just not fill whatever I want, essentially. But if it looked like it was illegitimate prescription, I'm just not going to do it, right? Okay, so for Schedule 2 substances, and these are going to be most of like your amphetamines used for ADHD, these are going to include the majority of your opioid pain meds. So the most common drugs you're going to be looking at from a C2 perspective. They can only write it for a total amount of 90 days worth. Okay, so 3 months worth of drug can be written at a time. They have to be written on tamper-evident paper, meaning if they try to photocopy it, it says void all over it. It has other things that try to make sure that it's not going to be copied or tampered with. And these cannot be transmitted over the phone. Now there's starting to be some electronic means to do this securely, but that is not as common as you might think. It needs to be actually on a handwritten prescription for the most part, handed over to the pharmacist, right? And these have to be hand signed. They cannot be done with a stamp. Can't be done electronically. Have to hand sign it. Okay. We'll cover the new rules regarding opioids later on. We actually talk about them more specifically, but it has a lot to do with how many days worth you can prescribe, and the type of pain you're treating, etc. But 3 through 5, they can have refills written for them. So no refills for Schedule 2s, but for 3 through 5, you can write to 6 months worth. And actually, they're only good for 6 months. So non-controlled prescriptions are good for 12 months. 3 through 5s are good for 6 months, and 2s typically need to be filled pretty soon after it's written there. Okay. Now, sometimes what you can do, especially for like ADHD meds, instead of having your patients come back and see you every single month, you can potentially write for 3 different prescriptions and say that, yes, I wrote it on today's date, but do not fill until next month. Do not fill until that month, right? So that way the patient has multiple scripts that they can take, and that way it's a total of 3 months, and then they would come back to you after that point, right? Okay, here's an example of what this counterfeit proof paper is, or tamper-evident paper. Notice it says void on it after you photocopy it. And again, this is only produced by certain vendors, so you have to actually be registered and get appropriate clearance to actually get these pads here. And again, do you want to pre-sign these? No, right? And keep a bunch in your lab coat pocket, because that's what you can walk off with that, and all of a sudden they can prescribe whatever they want under your name. That's just no good. Okay. Now, controlled substance quiz. Let's see what schedule these drugs fall under. So morphine. Anyone know what schedule that is? Schedule 2 substance, right? So high abuse potential, but is there a medical use for it? 100%. Yeah, absolutely. Treat it for pain. Good. How about cocaine? 1? Actually, Schedule 2. We actually can use it for ophthalmologic procedures or ENT procedures. It's a really good anesthetic, and it's also a really good vasoconstrictor. We actually carried cocaine for a short time at Nemours when we first opened, because our ENT doc said they were going to use it, and then they never used it, so we just got rid of it, right? But it's one of those things where you used to carry cocaine over there, right? So we give Viagra to little kids. We got cocaine over at the hospital. Like Pete's hospital is where it's at. Anyway, how about methamphetamine? That's actually Schedule 2 as well. Yeah, all the amphetamines basically fall under Schedule 2. An exception to that would probably be like MDMA or ecstasy. That falls under Schedule 1, right? No acceptable medical use for that. How about marijuana? Now, this is an interesting one, right? Because again, in Florida, what can we use it for any purposes? So Florida. So in Florida, we can use it for medical purposes, right? Federally speaking, marijuana is a Schedule 1. Right? So marijuana is really the oddball out of this group because even though federally it's still considered a crime to have any possession of marijuana, and that's why if you look at a lot of places like dispensaries, everything's like cash only for the most part because they can't have a bank account because they're technically doing illegal federal crimes anytime they're having a transaction, right? However, if you want to go and light up in front of the White House, you can do that, right? Because it's legal for medical use in Washington, D.C. Very strange country we live in. But regardless, the federal government says, okay, we're just not going to prosecute or go after any of this stuff if the states say it's okay to use. So that's kind of the big difference with marijuana.
There's a place in this group, I don't know, they're treated with marijuana, so.
So, I mean, we can use it for medical purposes, right? Patients would have to, I mean, we'll talk about this later, but patients have to get, go see a provider who is licensed to or registered to prescribe medical marijuana. They'll basically give them a screening. They'll give them their green card, so to speak, and then they can go to a dispensary and they'll be allowed to get a certain amount over a certain period of time.
But if it's Schedule 1, you said it's not, they cannot have it.
Right, so that's why it's the exception because federally it's a Schedule 1, but in the states have said it's okay to use for medical purposes, right?
So then cocaine is class 2 federally and state?
Mm-hmm. Yeah, sometimes you find the states will have a little bit of difference in terms of what they will make a certain schedule. So you guys remember like the bath salts were kind of a big thing in the synthetic marijuana, like K2s and spices and whatnot. So usually the states can move faster than the federal government can. And so we made a lot of those substances all Schedule 1 at one time versus in the federal government, they may not have scheduled it yet. And so here it's still more strict, so you'd follow that. So again, marijuana is the one exception, which is why I bring it up.
Does it have to, it has to be a physician?
Yeah, so PAs and NPs cannot prescribe for medical marijuana currently in Florida. That's one of the big differences there. So
That's the case for all the first schedule drugs?
that's only for marijuana. Marijuana is the one exception to that. But anything else is a Schedule 1 is a felony to have possession of.
Right, but as PAs can you so
Yeah.
not prescribe anything.
Yeah, so no Schedule 1 can be prescribed, right? Like I mentioned, marijuana is an exception, but because there's no acceptable medical use. Even though the states have decided, yes, there is an acceptable medical use, right?
Is marijuana number 1 because people can grow it themselves? And it's hard to control?
No, it's because there's a lot of stuff in the background about marijuana, why it became illegal in the first place. There's a lot of like institutionalized racism and stuff like that. There's lots of documentaries you can look up. Huh?
That's a whole other class.
It's a whole another class. Yeah, a lot of it had to do with like tobacco growers. I mean, this is like back in the wee early days of the country, things like that. But anyway, off topic. Let me finish this up real quick. Just know that different drugs can have different schedules in certain states. So as an example, there's a muscle relaxant called Soma or carisoprodol. It's a Schedule 4 here, but if you go into another state, it may not be scheduled. Okay, so sometimes it's very state dependent, and you'll get used to that depending on where you practice. But recent changes, as an example, hydrocodone was one of the number 1 most prescribed drug in the U.S., usually number 1. It got moved from a C3 up to a C2, which really regulated how tightly we control that drug, and it led to a lot of big decreases in the availability of it. And so, again, you could write for refills of hydrocodone. Now you can't do that anymore. Okay, so again, that helped to curtail some of the abuse of that drug. However, started to see increases in heroin use instead, but whatever. And then tramadol for a good long time before NPs and PAs could write for controlled substances. This was a really good pain med for you guys to write for because it was a partial opioid. It was a little bit better than something like an ibuprofen or Tylenol, but it was non-controlled, so you could write for it no problem. And we realized there's still abuse happening with it, so they bumped it up to a C4.
How do you keep up with all the changes so you don't get in trouble?
Usually the group that you work for will have education associated with that stuff, so they'll have like bulletins that go out and say, hey, here's big practice changes, here's big legal changes that happen. You'll be keeping up with your professional organizations, hopefully, and you can review a lot of that stuff. So
it's the DEA, I guess, who comes to us and tells us, okay, this is a change, or is
yeah, they'll put out like press releases and things like that. Yeah, but I mean, like with big prescribing changes like what just happened, usually like the groups you work for will help you out with that.
Okay.
So question, like if you have a prescription for marijuana and you cross state lines, that state doesn't have the law for it, then you can get in trouble,
Not just having the card itself, but maybe possession of the drug would be the issue. Yeah. So it just depends. Anyway, oops. So that's it for the material for the test. Is there any questions? It's pretty good. Only went 5 minutes over, so to speak. Anything at all? We're gonna, yeah. Yeah, so that's a new change that happened like in 2017. Basically, they made it so that PAs and NPs are able to get their own DEA number. Before, what would happen pretty frequently, especially like in the ERs where you'd be working, you would print out the script and you'd have your doc go and sign it, or your attending would sign off on it. Some places still do that because it's such a hassle for you guys to get your DEA license and it costs money to get all the courses and stuff. So it just depends. Any other questions? Yes, ma'am. Yeah, I got robbed at knife point my second day working at CVS. Yeah, it was not great. So I said, this isn't really for me. So I'm going to go work in the hospital, and if I get held up there, then I'm just getting out of pharmacy altogether. I'm still in pharmacy, so fortunately everything worked out. My second day, it was...
What did you do?
He said, where's the hydrocodone? He had a knife, and I said, it's right over here. Take as much as you like. No, nothing is worth. There's no drug here that is worth my life or anyone else's. So please take it. They eventually caught the guy. The pharmacist I was working with actually ran after he left and got his license, or got his plate number, and he had actually like left like an 8-month-old infant by itself in the house. Like, it was a really sad scene, but the guy ultimately ended up going to jail. But yeah, so don't do crimes. They don't pay. It turns out. I'll see you guys next time.